Anatomically speaking, the arm is a part of the upper limb that is between the shoulders and the elbow joint. It has only one bone called the humerus and an intricate network of muscles, vessels, and nerves distributed around it. The arm muscles are divided into two compartments separated by the humerus and the medial and lateral intramuscular septae. The first one is the anterior compartment, and this one houses muscles responsible for elbow flexion. So it's not a surprise that the anterior compartment is also called the flexor compartment. Then there's the posterior compartment. This one houses muscles responsible for elbow extension, so it's also called the extensor compartment. These two compartments mainly act on the elbow joint, but some muscles can also act on the glenohumeral joint. Now, the anterior compartment contains three muscles: the biceps brachii, or simply the biceps, the brachialis, and the coracobrachialis muscles. The biceps muscle usually has two heads, a short head and a long head. The short head attaches to the coracoid process of the scapula and descends anteromedially to the head of the humerus, while the long head attaches to the supraglenoid process of the scapula and descends into the intertubercular or bicipital groove. It is held in the bicipital groove by the transverse humeral ligament, which extends from the lesser to the greater tubercle of the humerus to turn the groove into a canal for the tendon of the long head. Both of these heads converge together and attach distally to the tuberosity of the radius, and blend with the fascia of the forearm via the bicipital aponeurosis. The bicipital aponeurosis is a triangular membranous band that runs across the cubital fossa to blend with the deep fascia covering the flexor muscles on the medial side of the forearm. The biceps is innervated by the musculocutaneous nerve and acts on three different joints: the glenohumeral, the elbow joint, and the proximal radioulnar joint, though it primarily acts on the latter two. On the glenohumeral joint, the biceps helps to prevent dislocation and stabilize the shoulder joint due to the tendon of the long head supporting the humeral head into the glenoid cavity. The biceps also has a minor role in flexing and adducting the arm. Most importantly, the biceps muscle acts on the humeroulnar joint by flexing the elbow joint. A practical example of this is when you lift up a heavy object, like a bag full of groceries. The biceps muscle also acts on the proximal radioulnar joint. Due to the orientation of the bicipital aponeurosis, flexion of the biceps pulls the aponeurosis and helps the supinator muscle to supinate the forearm, which is turning the palm upwards. To remember the action of forearm supination, think about cupping your hands together to form a bowl and using it to drink a bowl of soup. All right, the next muscle in the anterior compartment is the coracobrachialis, which lies in the superior part of the arm towards the medial side. Proximally, the coracobrachialis attaches to the coracoid process of the scapula, while distally it attaches to the middle third of the anteromedial surface of the humeral midshaft. So the coracobrachialis doesn't reach the elbow. As a member of the anterior compartment, it's also innervated by the musculocutaneous nerve. The coracobrachialis mainly helps to flex and adduct the glenohumeral joint. It also plays an important role in stabilizing the shoulder joint by resisting downwards dislocation. Finally, the third muscle in the anterior compartment of the arm is the brachialis. Proximally, the brachialis muscle attaches to the distal half of the anterior surface of the humerus. It then extends distally, crosses the elbow joint to attach to the coronoid process and tuberosity of the ulna. Unlike its neighbors in the anterior compartment, which are only innervated by the musculocutaneous nerve, the brachialis muscle is also innervated by the radial nerve. The brachialis only has one role. It flexes the forearm at the elbow joint, regardless of whether it's pronated or supinated. Now let's switch gears and look at the two muscles in the posterior compartment of the arm: the triceps brachii, or just the triceps, and the anconeus muscles, both of which are innervated by the radial nerve. With three bulky heads, the triceps is the main extensor of the forearm. Proximally, its long head attaches to the infraglenoid tubercle of the scapula. The lateral head to the posterior surface of the humerus, just superior to the radial groove. And finally, the medial head attaches to the posterior surface of the humerus, immediately inferior to the radial groove. As the muscle extends distally, all three of its heads fuse together, having a common distal attachment that is to the olecranon and the fascia of the forearm. All three heads contribute to the extension of the forearm. However, the medial head is the workhorse of the forearm extension. The long head in particular also helps stabilize the shoulder joint and prevents dislocation by resisting downward forces of the arm. It also helps extend and adduct the glenohumeral joint. Finally, let's talk about the anconeus, which is this small triangular muscle at the posterior aspect of the elbow. Proximally, the anconeus attaches to the lateral epicondyle of the humerus. It extends distally to attach to the lateral surface of the olecranon and the proximal ulna. The contraction of the anconeus assists the triceps in extending the forearm and adds some stability to the elbow joint. All right, now let's pause for a minute and see if you can identify the 5 muscles of the arm. Okay then, now let's have a look at the nerves of the arm. First, there is the musculocutaneous nerve. This nerve originates from the C5, C6, and C7 spinal nerve roots and emerges as the terminal branch of the lateral cord of the brachial plexus at the inferior border of the pectoralis minor muscle. It pierces the coracobrachialis muscle and continues distally, passing between the biceps and the brachialis. At this point, it sends branches that supply all of these 3 muscles, and then emerges lateral to the biceps with a new name, the lateral cutaneous nerve of the forearm, where it supplies the skin of the lateral forearm. Next, there's the median nerve, which originates from the C6, C7, C8, and T1 spinal roots, and arises from the medial and lateral cords of the brachial plexus, and descends from the axilla to the arm. In the arm, the median nerve initially runs on the lateral side of the brachial artery until it reaches the middle of the arm. At this point, the median nerve crosses the brachial artery over to the medial side. This nerve keeps descending in the cubital fossa, passing deep to the bicipital aponeurosis and the median cubital vein. Next, there's the ulnar nerve. It originates from the C8 and T1 spinal roots and emerges from the medial cord of the brachial plexus. It then travels from the axilla to the arm, passing anterior to the teres major attachment on the humerus and to the long head of the triceps muscles on the medial side of the brachial artery. In the middle arm, the ulnar nerve pierces the medial intermuscular septum to enter the posterior compartment of the arm, descending distally between the medial head of the triceps muscle and the medial intermuscular septum. In the distal arm, the ulnar nerve passes posterior to the medial epicondyle to enter the forearm. The median and the ulnar nerves only give small articular branches to the elbow. Other nerves that pass through the arm include the medial cutaneous nerves of the arm and the medial cutaneous nerve of the forearm. Both of these nerves carry fibers that originate from the C8 and T1 spinal roots, and they arise from the medial cord of the brachial plexus, providing sensory innervations. The medial cutaneous nerve of the arm supplies the skin on the medial side of the arm as far as the medial epicondyle, and the median cutaneous nerve of the forearm supplies the skin on the medial side of the forearm as far as the distal wrist. And let's just briefly touch on the cutaneous innervation of the proximal and distal lateral portion of the arm, which are innervated by the axillary nerve and the radial nerve, respectively. Let's wrap up on the nerves by looking at the radial nerve, which innervates muscles of the posterior compartment of the arm and forearm. The radial nerve originates from the C5 to T1 spinal roots and emerges from the posterior cord of the brachial plexus in the axilla. After it exits the axilla, the radial nerve enters the posterior compartment of the arm behind the tracheal artery and medial to the humerus. It then runs infralaterally in the posterior arm, accompanied by the profunda brachii artery, and passes around the shaft of the humerus in the radial groove. When it passes through the radial groove and reaches the lateral border of the humerus, it pierces the lateral intramuscular septum to enter the anterior compartment of the arm, then courses around to the lateral epicondyle to enter the cubital fossa, where it divides into deep and superficial branches. Okay, so before we continue, feel free to press pause and see if you can identify the median nerve, the radial nerve, and the medial cutaneous nerve of the arm. Moving on, let's have a look at the arteries in the arm. The main artery supplying blood to the structure of the arm is the brachial artery, which continues from the axillary artery after it passes the inferior border of the teres major muscle. In the arm, the brachial artery initially lies medial to the humerus, and it can be palpated here by pressing it against the medial aspect of the humerus. Then, the brachial artery travels inferolaterally in the arm, accompanied by the median nerve, which crosses anterior to it. When the brachial artery arrives in the mid-arm region, it gives off its biggest branch called the profunda brachii, also called the deep artery of the arm. But profundi brachii sounds fancier, doesn't it? The profunda brachii courses posterolaterally to the humerus between the long head and the lateral head of the triceps, traveling along the radial nerve in the radial groove. It terminates at the level of the elbow by dividing into the middle and radial collateral arteries that contribute to the periarticular arterial anastomosis around the elbow. Right after giving off the profunda brachii in the mid-arm region, the brachial artery gives off its second branch, the superior ulnar collateral artery. After it emerges, the superior ulnar collateral artery accompanies the ulnar nerve in the posterior aspect of the arm as it runs posterior to the medial epicondyle of the humerus. Here, the superior ulnar collateral artery anastomoses with the posterior ulnar recurrent artery and the inferior ulnar collateral artery, which all participate in the articular anastomoses around the elbow joint. The third branch of the brachial artery is the inferior ulnar collateral artery. It also originates medially in the distal arm, immediately superior to the medial epicondyle. Then it passes anterior to the medial epicondyle and terminates by anastomosing with the anterior ulnar recurrent artery. The brachial artery eventually terminates in the cubital fossa and has two main terminal branches called the ulnar and radial arteries, which go on to supply the hand and forearm. And you know it, after the arteries comes the veins. The arm has both superficial and deep veins, which freely anastomose with each other. The superficial veins, which course through the subcutaneous tissue, and the deep veins, which are usually buried deep in muscles and accompany major arteries. In the arm, we have two major superficial veins: the cephalic vein, which typically runs on the lateral aspect of the arm, and the basilic vein, which runs on the medial aspect. As the cephalic vein ascends from the anterolateral aspect of the forearm, it courses superiorly in the arm on the lateral side between the deltoid and pectoralis major muscles and the deltopectoral groove through the deltopectoral triangle. At this level, the cephalic vein empties into the terminal part of the axillary vein after it pierces the costocoracoid membrane of the clavicle pectoral fascia. On the medial aspect of the arm, the basilic vein also ascends from the medial side of the forearm. And when it gets to the middle of the distal third of the arm, the basilic vein pierces the brachial fascia to pass deep to it, running superiorly parallel to the brachial artery, eventually merging with the deep veins accompanying the axillary artery to drain into the axillary vein. In the arm, there's only one important deep vein, and that's the brachial vein, or rather the paired veins running with the brachial artery, known collectively as the brachial vein. The brachial vein begins at the elbow and results from the junction of the ulnar and the radial veins in the cubital fossa. As it ascends in the arm, the brachial vein accompanies the brachial artery, joins with the basilic vein to form the axillary vein. Finally, let's look at the lymphatic drainage of the arm. Just like the veins, we have superficial and deep lymphatic vessels. Superficial lymphatic vessels arise in the arm from the cubital lymph nodes located proximal to the medial epicondyle and medial to the basilic vein, and then ascend in the arm terminating in the lateral or humeral axillary lymph nodes. The most superficial lymph vessels accompany the cephalic vein and enter the apical axillary lymph nodes, or the more deltopectoral lymph nodes. The deep lymphatic vessels follow the course of the brachial vein, terminating into the humeral or lateral axillary lymph nodes. One last pause before we recap. Do you still remember the major branches of the brachial artery in the arm? Here's a hint, there's 3 of them. All right, as a quick recap, the anterior compartment of the arm contains 3 muscles: the biceps brachii, the coracobrachialis, and the brachialis. All 3 of these muscles are innervated by the musculocutaneous nerve, And the brachialis also receives innervation from the radial nerve. The posterior compartment of the arm only has two muscles, which are both innervated by the radial nerve, the three-headed triceps and the little anconeus. The major nerves in the arm are the median nerve, the ulnar nerve, the medial cutaneous nerve, the radial nerve, and the musculocutaneous nerve, all of which derive from the brachial plexus. The main artery of the arm is the brachial artery, and it gives its three main branches in the medial aspect of the arm: the profunda brachii and the superior and inferior ulnar collateral arteries. The superficial veins of the arm are the cephalic vein on the lateral aspect of the arm, which empties into the axillary vein, and the basilic vein located in the medial aspect of the arm, which merges with the brachial vein to form the axillary vein.
I know what you're thinking. Isn't the axilla just a fancy name for the armpit? Well, besides the axilla being notoriously ticklish, it's also where many important neurovascular structures enter and exit to reach their target locations. Think of it like a train station, with many trains passing through en route to delivering electrochemical signals, blood, and lymphatics to their appropriate destinations. Now let's start with the boundaries of the axilla. The axilla is located at the junction of the arm and thorax and connects superiorly to the neck, anteriorly to the pectoral region, inferolaterally to the upper limb, and inferomedially to the thoracic wall. The axilla is shaped like a pyramid that has an apex, a base, and four walls. The apex of the axilla is also called the cervicoaxillary canal, which is the door between the neck and the axilla. The cervicoaxillary canal is bounded by the first rib, clavicle, and superior edge of the scapula. The base of the axilla is formed by skin, subcutaneous tissue, and axillary fascia, and forms what is called the axillary fossa, or what we know as the armpit. Moving on to the four walls of the axilla, the anterior wall is made up by two muscles, the pectoralis major and pectoralis minor. The inferiormost aspect of the anterior wall is called the anterior axillary fold, and it's formed by the pectoralis major. The posterior wall of the axillary is formed mainly by the scapula and overlying subscapularis muscle. The inferior aspect of the posterior wall is formed by the teres major and latissimus dorsi muscles, inferiorly forming the posterior axillary fold. The medial wall is formed by serratus anterior muscle that overlies the first to fourth ribs and intercostal muscles. Finally, the lateral wall is a bony wall formed by the intertubercular sulcus of the humerus. Let's move on to the contents of the axilla. Right below the skin, there's a lot of fat and connective tissue. If you dissect deeper, you will see the axillary sheath that surrounds the axillary vein, which is the most superficial, as well as the axillary artery and the surrounding brachial plexus. The axilla also contains lymphatic vessels and axillary lymph nodes. Let's start with the axillary artery, which begins as a continuation of the subclavian artery at the lateral border of the first rib and extends to the inferior border of the teres major before turning into the brachial artery. The axillary artery is divided into three parts as it passes posterior to the pectoralis minor. The first part is between the lateral border of the first rib and the medial border of the pectoralis minor and is contained within the axillary sheath. The second part is posterior to the pectoralis minor, and the third part extends from the lateral border of the pectoralis minor to the inferior border of teres major. Each part of the axillary artery has a number of important branches. One memory trick is that the part number also tells you how many branches it has. The first part has one branch, the superior thoracic artery, which supplies the subclavius muscle, the muscles of the first and second intercostal spaces, as well as the superior aspect of the serratus anterior. The second part usually has two branches, the thoracoacromial artery and the lateral thoracic artery. The thoracoacromial artery comes out medial to the pectoralis minor as a short, wide trunk and divides into 4 branches deep to the pectoralis major. The acromial branch, which goes toward the acromion process of the scapula, the deltoid branch, which passes between the deltoid and pectoralis major muscles in the deltopectoral groove, the pectoral branch, which passes between the pectoralis major and minor and supplies both muscles, and the clavicular branch, which supplies the subclavius muscle and the sternoclavicular joint. The lateral thoracic artery travels along the lateral border of pectoralis minor towards the thoracic wall to supply the pectoralis muscles, serratus anterior, intercostal muscles, axillary lymph nodes, and the lateral aspect of the breast. The third part of the axillary artery has, you guessed it, 3 branches: the subscapular artery, anterior circumflex humeral, and the posterior circumflex humeral arteries. The subscapular artery is the largest branch of the axillary artery, which travels along the subscapularis muscle before quickly dividing into its terminal branches, the circumflex scapular and thoracodorsal arteries. The circumflex scapular artery turns posteriorly and passes between the subscapularis and teres major muscles to reach the dorsal surface of the scapula, where it forms an important anastomosis with the suprascapular artery around the scapula. The thoracodorsal artery travels with the thoracodorsal nerve to supply the latissimus dorsi muscle. The final 2 branches of the third part are the anterior and posterior circumflex humeral arteries, which can emerge from the axillary artery separately or as one trunk before dividing. These arteries encircle the surgical neck of the humerus and anastomose with each other, like an arterial hug for the humerus. The smaller anterior circumflex humeral artery passes deep to the coracobrachialis and biceps brachii and gives an ascending branch to supply the shoulder joint. The posterior circumflex humeral artery passes posteriorly between the teres major and minor muscles, along with the axillary nerve, to supply the glenohumeral joint, or the shoulder joint, and to the surrounding muscles, most importantly the deltoid muscle. Since this space between the teres major and minor muscles looks like a quadrilateral, it is called the quadrangular space. The medial side of the quadrangular space is formed by the long head of the triceps muscle, and the lateral boundary is formed by the humerus. Now that was a lot of info. Take a second to pause the video and see if you can label the branches of the axillary artery before we move on. Alright, now let's move on to the axillary vein. The axillary vein is formed by the union of the brachial veins and the basilic vein at the inferior border of the teres major. It ends at the lateral border of the first rib, where it turns into the subclavian vein. The axillary fat also contains 5 major groups of lymph nodes, which are collectively called the axillary lymph nodes. Time for some more spatial geometry. Imagine that 4 of these groups of lymph nodes are the corners of a pyramid with a triangular base. In the corners of the triangular base, there are the anterior, or pectoral, the posterior, or subscapular, and the lateral, or humeral nodes. Next, we have one group in the center of the pyramid, called the central nodes, and one group at the apex, called the apical nodes. The anterior nodes are located along the medial wall of the axilla and receive lymphatic drainage from the anterior thoracic wall and most of the breast. The posterior nodes are located along the posterior axillary fold and receive lymph from the posterior thoracic wall and the scapular region. The lateral nodes are located along the lateral wall of the axilla around the axillary vein and receive lymph from most of the upper limb. The lymph from the anterior, posterior, and lateral nodes passes through efferent lymphatic vessels towards the central nodes. These central nodes are located deep to the pectoralis minor muscle near the base of the axilla. Lymph from the central nodes then passes to the apical nodes, which also receive lymph from the lymphatic vessels accompanying the cephalic vein. Alright, As a quick recap, the axilla is a pyramid-shaped space that lies between the thorax and the arm and serves as a connection point between the arm, neck, thorax, and pectoral regions. It contains a number of neurovascular structures that are embedded in a fatty matrix, including the 3 parts of the axillary artery and their branches, the axillary vein and its tributaries, and the 5 groups of axillary lymph nodes.
Have you ever fallen asleep with your shoulder in a weird position, only to wake up with your arm completely asleep? Or hit the inside of your elbow, the famous funny bone, and cause part of your hand to go numb? This happens when we compress or bang the nerves found in our arms, all of which originate in the brachial plexus. The brachial plexus is a vast network of nerves originating from the anterior rami of C5 to T1, which extends through the axilla into the shoulder, arm, and hand, providing afferent or sensory nerve fibers from the skin, as well as efferent or motor nerve fibers to the muscles. Alright, so the brachial plexus is divided into 5 roots, 3 trunks, 6 divisions, 3 cords, and 5 terminal branches. The order can be remembered using the mnemonic, remember to drink cold beer. Additionally, there are branches that leave the brachial plexus at various points along its length. Since the branches that come off of the roots and trunks are located above the clavicle, they are sometimes called the supraclavicular branches of the brachial plexus. And since the branches that come off of the cords as well as the terminal branches are located below the clavicle, they're sometimes called the infraclavicular branches of the brachial plexus. Okay, so starting with the roots, the 5 roots come from the anterior rami of the last 4 cervical nerves, C5 through C8, as well as the anterior ramus of the first thoracic nerve, or T1. These roots usually travel between the anterior and middle scalene muscles along with the subclavian artery. These 5 roots give off some branches: the long thoracic nerve, which arises from C5 to C7 and gives motor innervation to the serratus anterior muscle, the dorsal scapular nerve from C5, which gives motor innervation to the rhomboid and levator scapulae muscles, and a contribution to the phrenic nerve from C5, which gives motor and sensory innervation to the diaphragm. At the inferior part of the neck, the 5 roots combine to form 3 trunks. C5 and C6 merge to form the superior or upper trunk. C7 remains as the middle trunk, and C8 and T1 merge to form the inferior or lower trunk. The superior trunk gives off another branch, the suprascapular nerve, which travels across the posterior triangle of the neck, which we can see here highlighted in blue, and through the scapular notch to give motor innervation to the supraspinatus and infraspinatus muscles. The superior trunk also gives off the nerve to subclavius, which gives motor innervation to the subclavius muscle. Okay, now that we've gone over the roots, trunks, and the supraclavicular branches, let's pause and do a quick quiz. Pause the video and see if you can identify them. Moving on, each trunk splits into an anterior and a posterior division as they travel through the cervicoaxillary canal, or the apex of the axilla, giving rise to a total of 6 divisions. Think of it as traveling through a wormhole, and on the other side, the 6 divisions regroup with each other to form 3 cords. The cords are named for their relationship to the second part of the axillary artery. So, lateral to the axillary artery, there's the lateral cord, which is formed by the anterior divisions of the superior and middle trunks. Posterior to the axillary artery, there's, you guessed it, the posterior cord, formed by the posterior divisions of the superior, middle, and inferior trunks. And medial to the axillary artery, there's the medial cord, formed by the anterior division of the inferior trunk. No surprises there. Now these cords sprout a number of branches. The lateral cord gives rise to the lateral pectoral nerve, which gives motor innervation to the pectoralis major muscle, and also the pectoralis minor muscle via a communicating branch to the medial pectoral nerve. The posterior cord gives rise to the upper and lower subscapular nerves, which give motor innervation to the subscapularis and the subscapularis and teres major muscles, respectively. There's a thoracodorsal nerve, sometimes called the middle subscapular nerve, which gives motor innervation to the latissimus dorsi muscle. Next, the medial cord gives rise to the medial cutaneous nerve of the arm and the medial cutaneous nerve of the forearm, which gives sensory innervation to the medial skin of the arm and forearm. And more proximally, there's the medial pectoral nerve, which gives motor innervation to the pectoralis minor and major muscles. And finally, the three cords give rise to the 5 terminal branches. The median nerve is formed by contributions from both the lateral and medial cords and is made up of fibers from C5 to T1. The other terminal branch of the lateral cord is the musculocutaneous nerve, which receives contributions from C5 to C7. In the axilla, the median nerve is anterior to the axillary artery. The musculocutaneous nerve quickly exits the axilla by piercing the coracobrachialis muscle. The posterior cord divides into 2 terminal branches, which are the axillary nerve, which is made up of contributions from C5 and C6, and the radial nerve, which is made up of contributions from C5 to T1. The axillary nerve travels with the posterior circumflex humeral artery, which is one of the branches of the third part of the axillary artery. It exits the axilla through the quadrangular space to travel around the surgical neck of the humerus. The radial nerve passes posterior to the axillary artery to exit the axilla and travel in the spinal groove of the humerus. Finally, the medial cord gives rise to 2 terminal branches, the medial contribution to the median nerve and the ulnar nerve, which is made up of fibers from C8, T1, and occasionally C7. I think you'll agree that the brachial plexus can be pretty overwhelming, so one tip for orienting yourself and finding those terminal branches is to look for the letter M that is formed by the musculocutaneous nerve laterally, the ulnar nerve medially, and the median nerve in the middle. Alright, we're almost there. Now that we've gone over the divisions, cords, and terminal branches, let's go ahead and do another quiz. See if you can identify the cords and their branches as well as the terminal branches. Since the terminal branches of the brachial plexus each have many motor and sensory functions, let's go ahead and summarize them here, starting at the shoulder joint and moving our way down towards the fingertips. First, the median nerve gives motor innervation to the muscles of the anterior forearm, except for flexor carpi ulnaris, and the ulnar, or medial half of flexor digitorum profundus. In the hand, it innervates the thenar muscles, which act on the thumb, and the lateral lumbricals. It also carries sensory innervation from the skin of the hand. On the palmar side, it innervates the lateral 3½ digits and the adjacent palm. On the dorsal side, it innervates the distal aspects of the lateral 3½ digits. The musculocutaneous nerve gives motor innervation to the muscles of the anterior arm. It then continues as the lateral cutaneous nerve of the forearm to supply sensory innervation to the lateral side of the forearm. The axillary nerve carries motor innervation to the teres minor and deltoid muscles. It also carries sensory information from the glenohumeral joint, or shoulder joint, and the skin covering the inferior portion of the deltoid. This area of skin innervated by the axillary nerve is also known as a Sargent's patch. The radial nerve gives motor innervation to all of the muscles of the posterior arm and forearm. It also provides sensory innervation to the skin of the posterior arm and forearm. In the hand, it only supplies sensory innervation on the dorsal side. Here, it innervates the lateral hand, the thumb, and the proximal 2nd to 4th digits. And finally, the ulnar nerve carries motor information to the flexor carpi ulnaris and the ulnar half of the flexor digitorum profundus. In the hand, it innervates most of the intrinsic muscles, except for a couple that are innervated by the median nerve. Just like the median and radial nerves, it also carries sensory information from the skin of the hand. On the palmar side, it supplies the medial 1.5 digits and the adjacent palm. On the dorsal side, it also innervates the medial 1.5 digits and the adjacent skin of the hand. Let's take one more pause here before we recap. Here's a picture of the palmar and dorsal sides of the hand. Can you remember which nerves carry sensory information from each region? Alright, as a quick recap. The brachial plexus originates from C5 to T1. These 5 roots combine to form 3 trunks. Each trunk splits into an anterior and a posterior division for a total of 6 divisions, which then regroup with each other and form 3 cords. Finally, the cords divide and give rise to 5 terminal branches, which are the musculocutaneous nerve, the axillary nerve, the radial nerve, the median nerve, and the ulnar nerve.
The elbow joint is a hinge type of synovial joint, and it's actually made up of 2 separate joints which work together as one. The first joint, called the humero-ulnar joint, is between the trochlea of the humerus and the trochlear notch of the ulna, and the second one, called the humero-radial joint, is situated between the capitulum of the humerus and the superior aspect of the head of the radius. A good way to remember this is thinking of the crazy tulips. The CRA in crazy represents the capitulum, which articulates with the radius, and the TUL in tulips represents the trochlea, which articulates with the ulna. The elbow joint is covered by a synovial membrane, which is surrounded by a joint capsule. The joint capsule extends from the margins of the articular surfaces of the capitulum and trochlea on the humerus to the coronoid process anteriorly and to the olecranon fossa posteriorly. On both the medial and lateral sides, the elbow joint is strengthened by 2 strong ligaments called the collateral ligaments, which are thickenings of the elbow joint capsule. On the medial side, also called the ulnar side, there's the ulnar collateral ligament, which extends from the medial epicondyle of the humerus to the coronoid process and the olecranon of the ulna. The ulnar collateral ligament actually consists of 3 separate bands: anterior, posterior, and oblique. The anterior band is the strongest, and it runs from the medial epicondyle to the tubercle of the coronoid process. This band helps limit elbow extension. Next, there's the fan-shaped posterior band, the weakest of all, and it runs from the medial epicondyle to the olecranon of the ulna. This helps limit elbow flexion. Finally, there is the thin oblique band, which makes the socket for the trochlea slightly deeper, reducing the chance of dislocation. On the lateral side, there's the radial collateral ligament, which extends from the lateral epicondyle of the humerus to the annular ligament which it blends with. The annular ligament encircles the radial head and binds it into the radial notch of the ulna, allowing for pronation and supination of the forearm. Now, the elbow joint is also surrounded by synovial fluid-filled bursae, which are basically pockets of synovial fluid that provide lubrication and reduce the friction when structures such as tendons, skin, muscles, and bones rub against each other with movement. There are 3 main elbow bursae. First, there's the subcutaneous olecranon bursa, which lies between the olecranon and the subcutaneous tissue. Then, the subtendinous olecranon bursa, situated between the tip of the olecranon and the triceps brachii tendon. And third, there's the intratendinous olecranon bursa, which lies within the triceps brachii tendon at the point of its insertion onto the olecranon. Finally, another important bursa, called the bicipitoradial bursa, is situated in the cubital fossa, which is a small, fat-filled, triangular space on the anterior aspect of the elbow. Specifically, the bicipitoradial bursa is situated between biceps brachii tendon and the tuberosity of the radius. As a hinge-type synovial joint, the elbow can do only two types of movements. That's what any hinge does, right? It opens and closes. The same goes for the elbow. This joint extends and flexes. Extension is mainly done by the triceps brachii, while flexion is mainly done by the brachialis and the biceps brachii muscles. The elbow joint receives its blood supply from the elbow's periarticular anastomosis, formed by the branches of the collateral and recurrent branches of the brachial artery, as well as the profunda brachii and the radial and ulnar arteries. Finally, regarding innervation, remember Hilton's law, which says that the nerves that innervate the muscles crossing over a particular joint also innervate that joint. So according to Hilton's law, the elbow joint is innervated by three nerves: the musculocutaneous nerve, the radial nerve, and the ulnar nerve. Before we wrap up, feel free to hit the pause button and see if you can remember the bands of the ulnar collateral ligament. Hint, there are 3 of them. Alright, as a quick recap, the elbow joint is a hinge-type synovial joint which allows flexion and extension of the elbow. On both the medial and lateral sides, the elbow joint is strengthened by the ulnar and radial collateral ligaments, respectively, which are thickenings of the elbow joint capsule that provide stability to the elbow joint. There are 3 main elbow bursae: the subcutaneous olecranon bursa, the subtendinous olecranon bursa, and the intratendinous olecranon bursa. Blood supply for the elbow joint comes from the periarticular anastomosis, while innervation is handled by the musculocutaneous, radial, and ulnar nerve.
The glenohumeral joint, also known as the shoulder joint, is a ball and socket type of synovial joint, the ball being the head of the humerus and the socket being the glenoid cavity of the scapula. The shoulder joint is the most mobile joint in our body, and it allows us to do everything from pull-ups to throwing a baseball and hugging our loved ones. Let's take a closer look at our articulating parts here. So the head of the humerus fits into the shallow glenoid cavity. The glenoid cavity is actually so shallow that it only covers 1/3 of the humeral head. Having a shallow glenoid cavity allows for exceptional mobility, as the humeral head can rotate freely to allow us an impressive range of motion. At the same time, the contour of the glenoid cavity is lined by a fibrocartilaginous rim called the glenoid labrum, which makes the cavity a little bit deeper, reducing the chance for dislocations. Like any respectable synovial joint, the glenohumeral joint is covered by a tough but loose joint capsule with an internal synovial lining. The joint capsule extends from the anatomical neck of the humerus to the margin of the glenoid. This capsule has 2 apertures, or passageways. The first one is between the tubercles of the humerus, which provides passage for the tendon of the long head of the biceps brachii. This tendon then passes in the intertubercular groove covered by a broad fibrous band called the transverse humeral ligament, which runs from the lesser tubercle of the humerus to the greater tubercle. The second aperture is situated inferior to the coracoid process, and it allows communication between the subtendinous bursa of the subscapularis and the joint synovial cavity. Speaking of which, there are actually 2 bursae around the glenohumeral joint, which are basically pockets of synovial fluid. There is one right under the acromion called the subacromial bursa, and another one between the capsule and the tendon of the subscapularis muscle called the subtendinous bursa of the subscapularis. The role of bursae is to provide lubrication and reduce the friction when structures such as tendons, skin, muscles, and bones rub against each other, especially the supraspinatus tendon, which rubs against the acromion as the joint moves. Now the joint capsule is reinforced by numerous ligaments. There are the glenohumeral ligaments, which are thickenings found within the joint capsule, the coracohumeral ligament, which runs from the scapula to the humerus, and the coracoacromial ligament, which runs from the coracoid process to the acromial process of the scapula. The glenohumeral ligaments are three bands called the superior, middle, and inferior glenohumeral ligament that radiate inferolaterally from the glenoid labrum to blend with the joint capsule, where it attaches to the anatomical neck of the humerus. These ligaments reinforce the anterior part of the joint capsule. Next is the coracohumeral ligament, which runs from the coracoid process of the scapula and then extends inferolaterally to attach to the greater tubercle of the humerus. The coracohumeral ligament strengthens the upper part of the capsule. Finally, the coracoacromial ligament runs above the head of the humerus from the acromion and coracoid process on the scapula. This creates an arch that overlies the head of the humerus to prevent it from slipping from the glenoid cavity superiorly. Another major contributor to the stability of the shoulder joint are the rotator cuff muscles. This is a set of four muscles that form a musculotendinous cuff around the shoulder. The rotator cuff muscles hold the humeral head in the glenoid cavity, and it also participates in arm movements, especially rotation, hence their name. You can remember the names of these muscles with the SITS mnemonic. This stands for supraspinatus, infraspinatus, teres minor, hence the lowercase t, and subscapularis. Notice that the inferior part of the joint capsule is not reinforced by rotator cuff muscles. So, this is the weakest area of the joint, which is where most dislocations occur. Now, the shoulder joint allows flexion and extension, which is moving the arm forward and backward in the sagittal plane, abduction and adduction, which is done in the coronal plane, medial rotation and lateral rotation, and finally circumduction, which occurs when the arm is held straight at the elbow joint while the whole limb moves around the shoulder as if it's drawing circles. The blood supply of the shoulder joint comes from the anterior and posterior circumflex humeral arteries, which are branches of the axillary artery, as well as from branches of the suprascapular artery, which is a branch of the thyrocervical trunk. Finally, regarding innervation, remember Hilton's law, which says that the nerves that innervate the muscles crossing over a particular joint also innervate that joint. So, for example, the deltoid muscles, triceps, and some rotator cuff muscles all cross the glenohumeral joint and act on it. These are all innervated by the axillary nerve. Therefore, the axillary nerve provides innervation to the glenohumeral joint via articular branches. The rest of the innervation is accounted for by articular branches of the suprascapular nerve and the lateral pectoral nerve. Before we wrap up, let's take a quick break to identify the ligaments surrounding the glenohumeral joint. Alright, as a quick recap, the glenohumeral joint, or the shoulder joint, is a ball and socket type of synovial joint between the head of the humerus and the glenoid cavity of the scapula. The glenoid cavity only covers 1/3 of the humeral head, which allows for exceptional mobility. At the same time, the contour of the glenoid cavity is lined by a fibrocartilaginous rim called the glenoid labrum, which makes the cavity a little bit deeper, reducing the chance for dislocations. The bursae around the shoulder joint are the subacromial and the subtendinous bursa, and they provide lubrication, reducing friction during arm movements. The shoulder joint is surrounded by a joint capsule, which is reinforced by ligaments. There are the glenohumeral ligaments, which are thickenings found within the joint capsule, the coracohumeral ligament, which runs from the scapula to the humerus, and the coracoacromial ligament, which runs from the coracoid process to the acromial process of the scapula. The rotator cuff muscles also provide stability to the shoulder joint, and they can be remembered with the sits mnemonic: supraspinatus, infraspinatus, teres minor, and subscapularis. The shoulder joint allows for flexion, extension, abduction, adduction, medial rotation, and lateral rotation, and circumduction.
The pectoral and scapular regions consist of various structures that include muscles, blood vessels, and nerves, which all act together to make our upper limbs functional. The muscles of the pectoral region are divided into groups based on their locations. There are axio-appendicular muscles, which extend between the axial and appendicular skeletons, and the scapulohumeral muscles, which specifically connect the scapula to the humerus. First, let's take a look at the axio-appendicular muscles, which are divided into two large groups, the anterior and posterior groups of muscles. The anterior axio-appendicular group is composed of four muscles: the pectoralis major, pectoralis minor, the subclavius, and the serratus anterior. The pectoralis major is a relatively flat, fan-shaped muscle which covers the upper half of the thorax. This muscle has two proximal attachments, also called heads. The first one is the clavicular head, which attaches proximally to the medial half of the clavicle. Below it, there's another much larger part called the sternocostal head, which attaches proximally to the anterior surface of the sternum and the superior 6 costal cartilages. Both the clavicular and the sternocostal heads converge distally and then attach to the lateral lip of the intertubercular groove of the humerus. Supralaterally, the clavicular head of the pectoralis major lies adjacent to the deltoid muscle. These muscles don't come completely together, thus creating a narrow gap between them that's called the deltopectoral groove, which is where the cephalic vein passes. Additionally, infralaterally, the sternocostal head of the pectoralis major twists and forms the anterior axillary fold. The pectoralis major muscle is innervated by two nerves: the lateral pectoral nerve and the medial pectoral nerve. The lateral pectoral nerve receives fibers from the anterior rami of C5, C6, and C7, and the medial pectoral nerve receives fibers from the anterior rami of C8 and T1, and they're also connected by a communicating branch. Both of these nerves arise from the brachial plexus, and their names tell which cords they're from. The lateral pectoral nerve takes a journey to reach its destination. First, it arises from the lateral cord and then passes across the axillary artery and vein before piercing the clavipectoral fascia to finally gain access to the deep surface of the clavicular head. On the other side, the medial pectoral nerve arises from the medial cord and curves anteriorly, passing between the axillary artery and vein. It then pierces pectoralis minor and then the sternocostal head of pectoralis major, innervating both of these muscles. Alright, so when these two heads of the pectoralis major muscle contract simultaneously, they produce adduction and medial rotation of the arm. Additionally, each muscle head can also contract independently. When the clavicular head contracts alone, it causes flexion of the arm, while the contraction of the sternocostal head extends it back from a flexed position. Alright, now let's talk about the pectoralis minor muscle, which is a triangular muscle situated deep to the pectoralis major in the anterior axillary wall. You can think of these two muscles as cousins, where the major covers and gives comfort to the minor one. The base of the pectoralis minor muscle attaches to the anterior surface of the third, fourth, and fifth ribs at the point where they meet their costal cartilages. The fibers of pectoralis minor converge towards its apex supralaterally into a tendon that attaches to the coracoid process of the scapula. The pectoralis minor is innervated by the medial pectoral nerve. And when the pectoralis minor contracts, it pulls on the coracoid process inferiorly and anteriorly against the thoracic wall, providing stability to the scapula by holding it tight to the thorax. It also helps during deep inhalation because this muscle can elevate the ribs as it contracts, thus increasing the volume of the thoracic cavity so more air can get into the lungs. Next in the anterior axioappendicular group is the subclavius, which is this small round muscle lying horizontally inferior to the clavicle and superior to the first rib. It's best seen when the arm is in the anatomical position. Proximally, the subclavius attaches to the first rib and its costal cartilage, while distally it attaches to the inferior surface of the middle third of the clavicle. This is where this muscle gets its name. The subclavius is innervated by the nerve to the subclavius, which receives fibers from the anterior rami of C5 and C6 via the superior trunk of the brachial plexus. The subclavius helps to stabilize the shoulder by anchoring and depressing the clavicle and also adding some strength to stabilize the acromioclavicular joint when you hit those heavy weights at the gym. Last but not least, there's the serratus anterior muscle, which forms the medial wall of the axilla and lies over the lateral part of the thorax. This is a fitting name for the muscle because serratus means saw, and the way this muscle's fibers are arranged on its anterior border gives it a saw-like appearance. The muscle originates on the external surfaces of the lateral parts of the upper 8 ribs and then prolong laterally and posteriorly to insert onto the whole length of the anterior aspect of the medial border of the scapula along with the inferior angle of the scapula. The serratus anterior is innervated by the long thoracic nerve, which originates from the anterior rami of C5, C6, and C7. When the serratus anterior contracts, it protracts the scapula, meaning it pulls it anteriorly and laterally along the back. This happens when you're trying to reach for something anteriorly or when making a punching motion, which is why this muscle is also referred to as the boxer's muscle. The serratus anterior also helps to anchor the scapula by holding it close to the thoracic wall, like when doing push-ups or pushing a car. Last but not least, this muscle also causes the scapula to rotate upwards, thus tilting its glenoid cavity like when abducting your arm above the head. Okay, so now let's pause and reflect a bit on what we've seen so far. In the meantime, can you recall the muscles of the anterior axioappendicular group and their innervations? The blood supply of both the pectoralis major and minor comes from the pectoral artery, which is one of the 4 branches of the thoracoacromial artery. The thoracoacromial artery originates from the second part of the axillary artery, which is the part of the axillary artery that lies posterior to the pectoralis minor. After branching off from the axillary artery, the thoracoacromial artery curls around the supromedial border of the pectoralis minor and then pierces the costocoracoid membrane of the clavipectoral fascia. After it emerges on the other side of the fascia, that's when it divides into 4 branches, in which the first is the pectoral artery. The pectoral branch passes between the pectoralis major and minor, where it provides branches that supply these 2 muscles. Next, the thoracoacromial artery gives the clavicular branch, which courses superiorly and medially to supply the subclavius muscle and the sternoclavicular joint. The thoracoacromial artery also gives the acromial branch, which runs superior to the coracoid process towards the acromion. Finally, towards the lateral side, the thoracoacromial artery gives the deltoid artery, which then crosses over the pectoralis minor muscle and then passes alongside the cephalic vein in the deltopectoral groove between the pectoralis major and deltoid muscle. At this level, the deltoid artery provides branches that supply both of these muscles. Now let's move to the muscles of the posterior axio-appendicular group. They're divided into two subgroups. The first subgroup consists of two superficial muscles, the trapezius and latissimus dorsi. The trapezius is this large triangular muscle extending from the posterior aspect of the neck to the superior half of the back. There's two trapezius muscles in the back, which when seen together look like a trapezium. Proximally, the trapezius attaches to the medial third of the superior nuchal line, the external occipital protuberance, the nuchal ligament, and the spinous processes of the C7 to T12 vertebrae. Distally, the trapezius attaches to the lateral third of the clavicle, the acromion, and the spine of the scapula. Based on the orientation of its fibers, the trapezius is divided into the ascending part, the middle part, and the descending part. This muscle is innervated by the spinal accessory nerve, which is cranial nerve 11, as well as by branches from the anterior rami of C3 and C4. Contraction of the descending part results in the elevation of the scapula, like when shrugging the shoulders. The contraction of the middle part retracts the scapula, while the contraction of the ascending part pulls the scapula downward, lowering the shoulder. And finally, when the ascending and descending fibers work together, it results in superior rotation of the scapula on the thoracic wall. The second superficial muscle is latissimus dorsi, which extends from the trunk to the humerus, acting directly on the glenohumeral joint and indirectly on the pectoral girdle. The latissimus dorsi is proximally attached to the iliac crest, thoracolumbar fascia, the inferior 6 thoracic vertebrae, and the inferior 3 or 4 ribs. Distally, the latissimus dorsi attaches to the floor of the intertubercular groove of the humerus. The latissimus dorsi is innervated by the thoracodorsal nerve, which receives fibers from the anterior rami of C6, C7, and C8. The contraction of latissimus dorsi extends and medially rotates the humerus, like when trying to scratch at that annoying itch in the middle of your back. It's also a powerful adductor and is the muscle used when pulling yourself up during rock climbing, chin-ups, or movements such as swimming or chopping wood. The second subgroup of the posterior axio-appendicular muscle group consists of two deep muscles, which are the levator scapulae and the rhomboids. The levator scapulae lies in the neck, deep to the sternocleidomastoid muscle and the trapezius. Proximally, it attaches to the posterior tubercles of the transverse processes of the C1 to C4 vertebrae and then descends to distally attach to the medial border of the scapula superior to the root of the scapular spine. The levator scapulae is innervated by the dorsal scapular nerve, which arises from the anterior rami of C4 and C5, as well as by direct branches from the anterior rami of the C3 and C4 cervical nerves. Levator roughly translates as lifter, so when this muscle contracts, it elevates the scapula. It also fixes the scapula and holds it in place to resist downward forces, like when carrying a heavy piece of luggage up the stairs. It also rotates the glenoid cavity inferiorly by rotating the scapula downwards. Now let's have a look at the rhomboids, the muscles that are immediately located deep to the trapezius. There are two of them, the rhomboid minor and the rhomboid major, which is below the minor. The proximal attachment of the rhomboid minor is to the nuchal ligament and the spinous processes of the C7 and T1 vertebrae. Distally, rhomboid minor attaches to the medial border of the scapula at the level of the spine of the scapula. The much larger rhomboid major proximally attaches to the spinous processes of the T2 to T5 vertebrae and distally to the medial border of the scapula inferior to the spine of the scapula. Both rhomboids are innervated by the dorsal scapular nerve, which receives fibers from the anterior rami of C4 and C5. Now, to help remember which vertebrae the levator scapulae and the rhomboid muscles originate from, you can recall the 4-2-2-4 rule. The levator scapulae originates from the first 4 vertebrae, C1 to C4. Then, none of these muscles originate from the next two vertebrae, which is C5 and C6. Then, rhomboid minor originates from the next two vertebrae, which is C7 and T1. And finally, rhomboid major originates from the next four vertebrae, which is T2 to T5. So, starting at the top of the vertebral column, 4 vertebrae for the origin of levator scapulae, 2 with no attachment, 2 for rhomboid minor, and 4 for rhomboid major. 4, 2, 2, 4. Okay, now back to the rhomboids. Rhomboid minor and major always contract together, producing scapular retraction and downward rotation of the scapula. They also assist the serratus anterior in holding the scapula against the thoracic wall. These movements enable us to forcibly lower the arm, like when driving a stake with a sledgehammer. Alright, now let's shift gears and then have a look at the scapulohumeral muscles, which pass from the scapula to the humerus. These 6 muscles, also referred to as the intrinsic shoulder muscles, are the deltoid, the teres major, and the 4 rotator cuff muscles. The rotator cuff muscles are the supraspinatus, infraspinatus, teres minor muscle, and subscapularis muscles. They're widely known as the sits muscles, and they're powerful rotators of the humerus. Take note that the small t represents the teres minor. Let's have a closer look at the deltoid first, which forms the rounded contour of the shoulder. Proximally, the deltoid attaches to the spine of the scapula, the acromion process, and the lateral third of the clavicle. Distally, it attaches to the deltoid tuberosity of the humerus. The deltoid is divided into 3 parts: the clavicular, acromial, and spinal parts. It's innervated by the axillary nerve, which receives fibers from the C5 and C6 spinal segments. When the 3 parts contract simultaneously, it results in arm abduction when the arm is already held at 15 degrees of abduction. The initial 15 degrees of abduction are done by the supraspinatus muscle. The parts of the deltoid muscle can contract independently, producing other arm movements. When the spinal part contracts alone, it produces extension and lateral rotation of the arm. When the acromial part of the deltoid contracts independently, it causes the arm to abduct, while the contraction of the clavicular part causes the arm to flex and medially rotate. The clavicular and spinal heads, also known as the anterior and posterior head, are used to swing the arms during walking. Next, there's the teres major muscle, which is a thick, rounded muscle attached proximally to the posterior surface of the inferior angle of the scapula. Distally, the teres major muscle attaches to the medial lip of the intertubercular groove of the humerus. As teres major travels from the scapula to the humerus, its inferior border forms the inferior border of the lateral part of the posterior wall of the axilla. This muscle is innervated by the lower subscapular nerve, which receives fibers from the anterior rami of C5 and C6. When teres major contracts, it adducts and medially rotates the arm. Alright, it's time to have a look at the legendary rotator cuff muscles, or simply the sits muscles. They form a cuff that surrounds the head of the humerus and holds it in the glenoid cavity, thereby stabilizing the glenohumeral joint. Okay, let's take a closer look at the supraspinatus first. This muscle arises in the supraspinous fossa of the scapula and then extends distally to attach to the superior facet of the greater tubercle of the humerus. It's innervated by the suprascapular nerve, which receives fibers from the anterior rami of C5 and C6. Instead of rotating the arm like the rest of the group, the contraction of the supraspinatus initiates abduction, which is moving the arms laterally away from the body. Next, there's the infraspinatus, which is a thick triangular muscle that attaches proximally to the infraspinous fossa of the scapula and extends distally to attach to the middle facet of the greater tubercle of the humerus. This muscle is also innervated by the suprascapular nerve, and when the muscle contracts, it rotates the arm laterally. Next up is the teres minor. This is a narrow, elongated muscle that attaches to the middle part of the lateral border of the scapula proximally and to the inferior facet of the greater tubercle of the humerus distally. The teres minor is innervated by the axillary nerve, which receives fibers from the C5 and C6 spinal segments. Just like the infraspinatus, the teres minor muscle rotates the arm laterally. Finally comes the subscapularis, a thick triangular muscle that proximally attaches to and fills the subscapular fossa. It then extends distally, forming the posterior wall of the axilla before attaching to the lesser tubercle of the humerus. The subscapularis is innervated by the upper and lower subscapular nerves, which receive fibers from the anterior rami of C5, C6, and C7. As a member of the rotator cuff club, the subscapularis rotates the arm. Unlike infraspinatus and teres minor, which are lateral rotators, the subscapularis performs medial rotation. Okay, I understand that this was too big of a bite to chew on at once, so let's take a pause and see if the sits muscles sit well in your memory by trying to remember their names and their origins and insertions. Alright, now I know what you're thinking. The shoulder and the pectoral regions are tightly packed with muscles and other various structures. Partly true. But between these large muscles, there are also gaps called anatomical spaces. Anatomical spaces serve as passageways for nerves or vessels. You can think of these like freeway on and off ramps that closely intersect with each other. One such anatomical space in the scapular region is called the quadrangular space. From a posterior view, the quadrangular space is bounded superiorly by the inferior border of the teres minor muscle. The inferior border is bounded by the superior border of teres major, the medial border by the lateral side of the long head of the triceps brachii muscle, and the humeral shaft constitutes the lateral border. The quadrangular space provides passage to the axillary nerve and the posterior circumflex humeral artery as they move through the posterior wall of the axilla to enter the scapular region. As we've discussed, the axillary nerve innervates the teres minor and deltoid muscles, and the posterior circumflex humeral artery supplies the deltoid, teres minor and major, and the long head of the triceps brachii. These structures also innervate and supply the glenohumeral joint. Another important space to look at is the triangular space, which is also located in the axilla medial to the quadrangular space. When viewed posteriorly, its superior border consists of the inferior border of teres minor. The lateral border of this space is bound by the medial border of the long head of the triceps brachii muscle, while the inferior border of this triangular space is bound by the superior border of the teres major muscle. The triangular space provides the passageway to the circumflex scapular artery as it branches off from the subscapular artery and curves around the lateral border of the scapula. It passes posterior between the subscapularis and teres major to supply muscles on the back of the scapula. Then it joins the arterial anastomosis around the scapula. Okay, now let's shift gears again and talk about the suprascapular nerve and artery which innervate and supply blood to different local muscles. The suprascapular nerve arises from the upper trunk of the brachial plexus, receiving fibers from the anterior rami of C5, C6, and sometimes C4. It courses laterally across the posterior triangle of the neck superior to the brachial plexus, and then through an area called the suprascapular notch, which is inferior to the superior transverse scapular ligament to innervate the supraspinatus and infraspinatus muscles. Running with the suprascapular nerve, we have the suprascapular artery, which arises from the thyrocervical trunk in the neck. However, instead of traveling below the superior transverse scapular ligament in the suprascapular notch, the artery passes over top of this ligament to supply the supraspinatus and eventually descends behind the neck of the scapula to supply the infraspinatus. A good way to remember what travels above and below the superior transverse scapular ligament is to think of it as a bridge, and remember the phrase Army over Navy. The A in Army represents the artery going over top of the ligament, or bridge, and the N in Navy represents the nerve. And we can remember this because the Navy travels on the water, which goes under bridges. The suprascapular artery is important because it's involved in a network of anastomosing arteries located around the scapula. There are several arteries in this network, including the dorsal scapular artery, branching from the transverse cervical artery, traveling along the medial border of the scapula, the suprascapular artery as it branches in the supraspinous fossa and infraspinous fossa, and the circumflex scapular artery as it travels along the posterolateral border of the scapula from its origin from the subscapular artery, which arises from the axillary artery. Other areas of anastomosis are the anterior and posterior circumflex humeral arteries. These arterial anastomoses are very important, as they form an interconnected channel of vessels through which blood can still flow to the muscles, even in case of a crisis like a stenosis, occlusion, or damage to one of the contributing arteries. Let's take an example. In scenarios where the axillary artery is ligated or occluded between the first rib and the subscapular artery, such as in atherosclerosis, this would result in a loss of blood flow distal to this area. However, the anastomosis between the subscapular artery, the suprascapular artery, and the dorsal scapular artery provide an anastomosis which would allow blood to reverse its flow through the subscapular artery and reach the third part of the axillary artery. That was a lot, so press pause and stretch a little bit and see if you can answer the following question. Does the posterior circumflex humeral artery pass through the quadrangular space or the triangular space? And now let's review the movements of the scapula and discuss the muscles that contribute to each movement. First, scapular elevation, which is an upward translational movement, is done mainly by the descending part of the trapezius muscle, with contribution from the levator scapulae and the rhomboids. Depression, which is a downward translational movement of the scapula, is primarily a passive movement done by gravity. Active depression of the scapulae is done by the sternocostal head of the pectoralis major muscle, the latissimus dorsi, the ascending part of the trapezius muscle, the inferior part of the serratus anterior, and the pectoralis minor. The scapulae also undergo protraction, which is when the scapulae are abducted away from the spine or pulled forward. This movement is mainly done by the serratus anterior as well as by the pectoralis major and pectoralis minor. Then there's retraction, which is squeezing the scapulae together towards the midline of your back. This is also known as adducting the scapulae towards the spine. This movement is principally made by the middle part of the trapezius muscle with help from the rhomboids and the latissimus dorsi. Next, there's upward rotation of the scapula that results in an upward tilt of the glenoid cavity in the coronal plane. This movement is done by the inferior part of the serratus anterior and the descending and ascending parts of the trapezius. Finally, there's downward rotation of the scapula, which results in a downward tilt of the glenoid cavity. This one is made possible mainly by the latissimus dorsi, with contributions of other muscles that include the levator scapulae, rhomboids, the pectoralis minor, the sternocostal head of the pectoralis major muscle, as well as gravity. Finally, let's have a look at the muscles that abduct the arm, starting with the supraspinatus. This muscle abducts the arm from 0 to 15 degrees. From here, the deltoid muscle takes over to abduct the arm the rest of the way. However, as the arm is abducted, the scapula also upwardly rotates. This is known as scapulohumeral rhythm. The movement occurs in a 2-to-1 ratio. For every 3 degrees of elevation, approximately 2 degrees occurs at the glenohumeral joint and 1 degree at the scapulothoracic joint. Hence, when the arm has moved 180 degrees so that it's vertical at the side of the head, 120 degrees occurred at the glenohumeral joint and 60 degrees occurred due to upward rotation at the scapulothoracic joint. Recall that the upward rotation is done by the trapezius and serratus anterior muscles, which along with the supraspinatus and deltoid work together to bring your arm from full adduction to full abduction. Alright, as a quick recap, there are 4 anterior axioappendicular muscles, which are the pectoralis major, pectoralis minor, the subclavius, and the serratus anterior, as well as the 4 posterior axioappendicular muscles, which are the trapezius, latissimus dorsi, the levator scapulae, and the rhomboids. Next are 6 scapulohumeral muscles, which are the deltoid muscle, teres major, plus the 4 rotator cuff or sits muscles. These are the supraspinatus, infraspinatus, teres minor, and subscapularis, all of which support and act on the glenohumeral joint. There's also the deltopectoral groove situated between the pectoralis major and deltoid muscle where the cephalic vein is found running superficially. In the axilla, there are two important anatomical spaces, the quadrangular space and the triangular space. Next, there are the suprascapular nerve and artery, which travel together downwards and laterally to the superior transverse scapular ligament. This is where the suprascapular nerve passes below the ligament and the suprascapular artery passes above it to supply the supraspinatus and infraspinatus. There's also an important network of arterial anastomoses around the scapula, which include the suprascapular artery, the subscapular artery, scapular circumflex artery, and the dorsal scapular artery. The movements of the scapula include elevation, depression, protraction, retraction, upward rotation, and downward rotation. Finally, regarding abduction of the arm, the supraspinatus abducts from 0 to 15 degrees, and then the deltoid muscle takes over to keep abducting the arm. As the arm is abducted, the scapula must be rotated upwards by the trapezius and serratus anterior.
The radio-ulnar joints are two joints between the two bones of the forearm, the ulna on the medial side and the radius on the lateral side. There's one superior or proximal radio-ulnar joint and one inferior or distal radio-ulnar joint, and together they allow for the movements of pronation and supination. This is going to be short and sweet, so let's dive right in. The proximal radio-ulnar joint is a pivot type of synovial joint, which consists of the head of the radius articulating with the radial notch of the ulna. The radial head is tightly bound into the radial notch of the ulna by the annular ligament that secures it in place. The two articulating surfaces are covered by a synovial membrane, over which lies the joint capsule. The joint capsule of the proximal radio-ulnar joint is an extension of the elbow's joint capsule. Next up, in the distal forearm, the radius and the ulna form another pivot type of synovial joint called the distal radio-ulnar joint, which is also covered by a fibrous joint capsule lined internally with a synovial membrane. For this joint, the rounded head of the ulna articulates with the ulnar notch of the distal radius. The articulating surfaces are mainly bound together by a fibrocartilaginous structure called the articular disc, which is triangular in shape, so it's also known as the triangular ligament. The articular disc attaches to the edge of the ulnar notch of the radius and the base of the styloid process of the ulna. The distal radio-ulnar joint is reinforced by the two important ligaments, the anterior and the posterior ligaments. These ligaments extend transversely from the radius to the ulna across the anterior and posterior surfaces of the joint. Both the proximal and distal radio-ulnar joints are responsible for forearm pronation, or the turning of the palm downwards on a flexed elbow, and supination, which is turning the palm upwards. To remember this, think about cupping both your hands and bringing them together to hold a bowl of soup, which mimics the movement of supination. For both these movements, the ulna remains relatively fixed and the radius moves over it. During pronation, the radial head rotates medially within the annular ligament at the proximal radio-ulnar joint, while the distal end of the radius is crossing over the ulna anteriorly and medially at the distal radio-ulnar joint. Pronation is done primarily by the pronator quadratus muscle, with a little help from the pronator teres. During supination, the radial head rotates laterally at the proximal radio-ulnar joint and causes the radius to uncross the ulna at the distal radio-ulnar joint, making the bones parallel again. Supination is done by two muscles, the supinator and the biceps brachii. Alright, as a quick recap, the proximal radio-ulnar joint is a pivot type of synovial joint, which consists of the head of the radius articulating with the radial notch of the ulna. The distal radio-ulnar joint is also a pivot type of synovial joint, and it consists of the rounded head of the ulna that articulates with the ulnar notch of the distal radius. Both the proximal and distal radio-ulnar joints are responsible for forearm pronation, or the turning of the palm downwards on a flexed elbow, and supination, which is turning the palm upwards. Joints are structures in which bones meet to either permit movement or provide stability. There are plenty of them in our upper limbs. We've got the sternoclavicular, the acromioclavicular, and the glenohumeral joints in the pectoral girdle, the elbow, the proximal and distal radio-ulnar joints in the forearm, the wrist joint, and the joints of the hand, which include the carpometacarpal, the intermetacarpal, the metacarpophalangeal, and the interphalangeal joints. So let's get acquainted with the first two of these joints. First up, there's the sternoclavicular joint, which is the only bony articulation attaching the upper limb to the axial skeleton. It involves the clavicular notch of the manubrium, the medial end of the clavicle, and a small part of the first costal cartilage. It is a saddle synovial type of joint, named so because the manubrial articulating surface is concave and the clavicular articulating surface is convex, so they fit together the same way that a cowboy sits on his horse's saddle. The joint has an articular disc that is firmly attached to the anterior and posterior fibrous joint capsule by the anterior and posterior sternoclavicular ligaments, as well as the interclavicular ligament. Like any other synovial joint, the articular surfaces of the sternoclavicular joint are covered by the fibrous joint's capsule, which has 4 ligamentous thickenings, simply called ligaments, lined internally by a thin layer of synovial membrane. The ligaments of the fibrous capsule are the anterior and the posterior sternoclavicular ligaments, which reinforce the joint capsule anteriorly and posteriorly, the interclavicular ligament, which strengthens the sternoclavicular joint superiorly, and finally there is the costoclavicular ligament, which anchors the inferior surface of the medial end of the clavicle to the first rib and its costal cartilage, providing stability to the sternoclavicular joint by limiting the elevation of the pectoral girdle. And second, there's the acromioclavicular joint. It lies between the lateral end of the clavicle and the tip of the acromion of the scapula. It's a plane type of synovial joint, meaning its articular surfaces are almost flat. Usually, there is a wedge-shaped articular disc between the articulating surfaces. The acromioclavicular joint is surrounded by a tough fibrous joint capsule with an internal synovial membrane that lines it. The acromioclavicular ligament strengthens the acromioclavicular joint superiorly and extends from the acromion to the clavicle. The acromioclavicular ligament alone can't hold this joint though, so it's reinforced by other ligaments further away from the joint, which are known as extrinsic ligaments. First, there is the coracoclavicular ligament, which is in fact 2 ligaments combined together to strongly anchor and fix the clavicle to the coracoid process. These are the conoid and the trapezoid ligaments. The conoid ligament is shaped, well, like a cone. Its base is attached to the conoid tubercle located at the inferior surface of the clavicle, and the apex attached inferiorly to the root of the coracoid process. And the trapezoid ligament, you guessed it, looks like a trapezoid. So no surprises here. It's attached to the superior surface of the coracoid process, from where it extends laterally to the trapezoid line on the inferior surface of the clavicle. Alright, before we wrap up, feel free to hit the pause button and see if you can remember the ligaments of the sternoclavicular and acromioclavicular joint. Alright, as a quick recap, the sternoclavicular joint is a saddle synovial type of joint, and it's the only bony articulation that attaches the upper limb to the axial skeleton. It has 4 ligaments, the anterior and the posterior sternoclavicular ligaments, which reinforce the joint capsule anteriorly and posteriorly, the interclavicular ligament, which strengthens the sternoclavicular joint superiorly, and the costoclavicular ligament, which provides stability to the sternoclavicular joint by limiting the elevation of the pectoral girdle. The acromioclavicular joint is a plane-type joint that lies between the lateral end of the clavicle and the tip of the acromion. It is supported by the acromioclavicular ligament and the coracoclavicular ligament, which is made up of the conoid and trapezoid ligaments.
The upper limb is connected to the axial skeleton, which is the cranium, vertebral column, and associated thoracic cage, by the bony pectoral girdle at the sternoclavicular joint, which is the connection between the clavicle and the sternum. Each upper limb is made up of 32 bones, and has a number of different regions. First, there's the pectoral girdle, which consists of 2 bones, the scapula, also called the shoulder blade, and the clavicle, also known as the collarbone. Then there's the arm, which only has 1 bone, called the humerus. Then we have the forearm, which has 2 bones called the radius and the ulna. Next, there's the wrist, which has 8 carpal bones. And finally, the hand, which has 5 metacarpal bones. And the fingers, who have 14 phalanges in total. Alright, now let's have a look at the shoulder girdle first. The shoulder girdle consists of the scapula and clavicle, and articulates anteriorly with the manubrium of the sternum. Starting with the scapula, it's a flat triangular bone located on the posterior aspect of the shoulder, extending over the 2nd to the 7th ribs. The scapula helps to connect the rest of the upper limb to the trunk, while stabilizing and assisting the shoulder during movement while serving as an attachment point for numerous muscles and ligaments. Now, like any respectable triangle, the scapula has 3 borders. The shortest and the thinnest of them is the superior border. Then there's the medial border, which runs parallel to the vertebral column. And finally, there's the lateral border, which is the thickest one. The lateral border is also known as the axillary border, because it points towards the axilla, or armpit region. The point where the medial and lateral borders meet is the inferior angle. And we also have the superior angle, which is the junction of the superior and medial borders. At the lateral part of the superior border, there's a small indentation called the scapular notch, through which the suprascapular nerve passes. Immediately lateral to the notch, the scapula has a bony projection called the coracoid process, which is this bony hook that first projects anteriorly, and then curves toward the lateral side similar to a bent finger. The coracoid process serves as an attachment point for 4 structures, including the coracoacromial ligament, the pectoralis minor muscle, the coracobrachialis muscle, and the short head of the biceps brachii. Alright, now the anterior surface of the scapula has a wide depression called the subscapular fossa, which is where the subscapularis muscle attaches. If we flip the scapula over, we can see its posterior surface. Below the superior border, there's a prominent ridge of bone called the spine of the scapula, which becomes broader as it extends laterally and superiorly to give rise to the acromion process, or simply the acromion. The surface below the spine of the scapula is called the infraspinous fossa, where infra means below, and spinous refers to the spine of the scapula. This is where a muscle called the infraspinatus attaches. The space above the spine is called the supraspinous fossa, and as you might have guessed it, well, it has an attachment point for the supraspinatus muscle. No surprises here. The spine of the scapula also has an attachment point for the deltoid muscle on the deltoid tubercle of the spine, in addition to attachments for the trapezius muscle. Inferior to the coracoid process, on the superior lateral surface of the scapula, there's the glenoid cavity, which is a shallow, cup-like fossa facing the lateral side. The glenoid cavity fits the head of the humerus to form the glenohumeral, or shoulder joint, and the coracoacromial ligament stabilizes this joint. Just above the glenoid cavity, there's a small bony bump called the supraglenoid tubercle, which serves as an attachment point for the long head of the biceps brachii muscle. Again, immediately below the glenoid cavity, there's another bony bump called the infraglenoid tubercle, which serves as an attachment point for the long head of the triceps brachii muscle. Alright, now the tip of the acromion articulates with the lateral end of an S-shaped bone called the clavicle, forming the acromioclavicular joint, which helps with stability and motion of the shoulder joint. The medial end of the clavicle is enlarged and triangular shaped, and articulates with the manubrium, which is the upper part of the sternum, to form the sternoclavicular joint. The medial 2/3 of the clavicle are convex anteriorly, and the lateral third is flattened and concave anteriorly. On the inferior surface of the clavicle, immediately medial to its lateral end, there's a small, oblique ridge of bone called the trapezoid line, where the trapezoid ligament attaches. Medial to the trapezoid line, there's the conoid tubercle, which is where the conoid ligament attaches. Both the trapezoid and the conoid ligaments help stabilize the pectoral girdle. Finally, the inferior side of the clavicle has a shallow groove called the subclavian groove, where the subclavius muscle attaches. When determining the orientation of the clavicle, it's good to remember that the lateral portion is flat, and the inferior surface is rough compared to the smooth superior surface. Finally, the clavicle's most important job is to suspend the scapula away from the trunk, allowing the upper limb maximum freedom of motion. The clavicle is also one of the bony boundaries of the cervico-axillary canal, which is a passageway that extends between the upper limb and the neck. So the clavicle also protects the neurovascular bundle supplying the upper limb. Alright, now that was a lot of info. Feel free to take a second to pause the video and see if you can label these missing parts of the scapula from A to F. Alright, so now let's look at that single bone in the arm, the humerus. The humerus is the largest bone of the upper limb. Proximally, the humeral head articulates with the glenoid cavity to form the glenohumeral joint, while the distal end of the humerus articulates with the radius and the ulna distally to form the elbow joint. Lateral to the humeral head, there's a bony protuberance called the greater tubercle, and anterior to it is the lesser tubercle, which is more on the anterior humerus. The greater tubercle is an attachment point for the supraspinatus, infraspinatus, and teres minor muscles, while the lesser tubercle is an attachment point for the subscapularis muscle. Between these two tubercles, there's a narrow groove called the intertubercular sulcus, or the bicipital groove, because the tendon of the biceps brachii muscle passes through it. Just below the humeral head, there's the anatomical neck of the humerus. This is formed by a groove separating the humeral head from the greater and lesser tubercles, and is where the glenohumeral joint capsule attaches. Distal to the tubercles, there's the surgical neck of the humerus, which is where the broad proximal part of the humerus meets the narrow humeral shaft. This makes the surgical neck relatively weaker and thus a common site for humeral fractures. On the posterior surface of the shaft, there's a shallow but broad bone depression called the radial groove, which is where the radial nerve passes through. On the lateral side of the shaft, there's a rough small bump called the deltoid tuberosity, which is where the deltoid muscle attaches. Toward its distal end, the humerus flattens a bit, giving rise to two bony projections known as the medial and lateral epicondyles. Above the lateral epicondyle, there's the lateral supracondylar ridge, which is the roughened ridge of bone where the extensor carpi radialis longus, the brachioradialis muscle, and the triceps brachii muscles attach. Above the medial epicondyle, there's the medial supracondylar ridge, which serves to attach the medial head of the triceps, the brachialis, and the pronator teres. Finally, the tip of the distal humerus, referred to as the condyle of the humerus, has two articular surfaces, which makes sense as it articulates with the two bones of the forearm, the radius and the ulna. Medially, there's the trochlea, which literally translates to pulley, which is lucky because it really looks like one. The trochlea articulates with the trochlear notch of the ulna. And laterally, there's the capitulum, which articulates with the head of the radius, and it literally means tiny head, because it looks a bit like a tiny bald head. It can be tough to remember which fossa articulates with which bone, so you can try and remember the phrase, crazy tulips. The CRA in crazy represents the capitulum articulating with the radius, and the TUL in tulips represents the trochlea articulating with the ulna. On the anterior surface of the humerus, proximal to the trochlea, there's a small depression called the coronoid fossa. Lateral to the coronoid fossa, there's the radial fossa, which sits just proximally to the capitulum. During flexion of the elbow, the coronoid fossa receives the coronoid process of the ulna, while the radial fossa is a cozy place for the radial head. If we flip the bone and look on the posterior side just at the same level, there's a much larger depression called the olecranon fossa, which accommodates the olecranon process of the ulna when the forearm is fully extended. Next up, there's the forearm, which is made of two parallel bones, the ulna, medially, and the radius, laterally. You can remember their position when you text your friends, really? The ulna is the main stabilizing bone of the forearm. At its proximal end, the ulna articulates with the trochlea of the humerus, and the head of the radius laterally. To articulate with the humerus, the ulna has two prominent projections. The olecranon, which forms the point of the elbow and sits in the olecranon fossa when the elbow is extended, and the coronoid process, which projects anteriorly and sits in the coronoid fossa when the elbow is flexed. These two processes form the trochlear notch, which grips the trochlea like a wrench. Slightly distal to the coronoid process, there's the ulnar tuberosity, a bony bump where the brachialis muscle inserts. On the lateral side of the coronoid process, there's a smooth concavity called the radial notch of the ulna, which articulates with the disc-shaped head of the radius, forming the proximal radial ulnar joint. The radial head is tied to the radial notch of the ulna by a ring-shaped ligament called the annular ligament. On the lateral side of the ulna, inferior to the radial notch on the lateral ulna, is a supinator crest, which is the attachment of the deep part of the supinator muscle needed for forearm supination. Looking at the shaft of the ulna, its lateral side forms a long ridge of bone called the interosseous border of the ulna, where the interosseous membrane attaches. The interosseous membrane, inter meaning between and osseous meaning bone, is a dense connective tissue that connects the ulna and radial shafts so that the forearm bones move as one. Distally, the shaft of the ulna ends with a round area called the head of the ulna, which stops short and does not participate in the radiocarpal joint of the wrist. Toward the posterior side of the head of the ulna, there's a small bony projection called the styloid process of the ulna, which is where the ulnar collateral ligament of the wrist attaches. Now let's have a look at the radius, which runs parallel and lateral to the ulna. On the proximal part of the radial head, there's a concave depression for when it articulates with the capitulum of the humerus during flexion and extension. The radial head itself is also disc-shaped in nature, which is important during pronation and supination, or turning your forearm from keyboard typing position to anatomical position. The medial side of the radial head articulates with the radial notch of the ulna, forming the proximal radial ulnar joint. Immediately below the radial head, there's the narrow radial neck, and distal to it on the medial side, there's an oval-shaped bony protuberance called the radial tuberosity. The radial tuberosity has two parts, the posterior one, which is rough, and the anterior part, which is smooth. The posterior part is where the tendon of the biceps brachii muscle inserts. Distal to the radial tuberosity, there's the radial shaft, which becomes broader distally and bends slightly toward the medial side. On its medial side, there's the ulnar notch, where part of the ulnar head fits to form the distal radioulnar joint. On its posterior side, the distal radius has a bony prominence called Lister's tubercle, or dorsal tubercle of the radius, which can be palpated on the dorsum of the wrist. At the tip of the distal radius, there's a smooth, slightly concave surface that articulates with carpal bones, specifically the scaphoid and the lunate, to form part of the radiocarpal joint, commonly called the wrist. On the lateral side of the distal radius, there's a pointed bony projection called the styloid process of the radius, which projects more distally than the ulnar styloid process. Now, feel free to take a quick break and pause the video to test your radius of knowledge on the forearm bones. Can you label these missing parts A, B, C, D, and E on the following image? Alright then, next up there's the wrist, which is the base of the hand. The wrist is made up of 8 small carpal bones, which are arranged in 2 rows of 4 bones each along the flexibility of the wrist. Looking at it from an anterior view, from lateral to the medial, the proximal row has the scaphoid bone, which means boat-shaped, the moon-shaped lunate bone, the 3-corned pyramid-shaped triquetrum, and finally the pisiform, which looks like a pea. On the distal row, but going from medial to lateral instead, there's the hooked hamate bone, the capitate, which looks like a small head, the wedge-shaped trapezoid bone, and the table-looking trapezium. The hamate bone has a prominence termed the hook of the hamate, where the ulnar nerve enters the hand by passing medial to the hook of the hamate through a groove between it and the pisiform bone. The scaphoid and the lunate are the only carpals that articulate directly with the distal radius, forming the radioscapholunate joint, or the radiocarpal joint to make things simple. At the tip of the distal ulna, there's a fibrocartilaginous pad that spans the styloid process of the ulna, and part of the distal end of the radius on the medial side. This pad separates the ulna from the closest carpals, which are the lunate and the triquetrum. So since it might be hard to cram all of these 8 carpals, let's use a cool mnemonic to remember their order. So long to pinky, here comes the thumb. This mnemonic helps you remember the bones in a U shape, starting from the lateral to medial in the proximal row, and then going from medial to lateral in the distal row. This also helps us remember that the pisiform is by the pinky, and the trapezium is by the thumb. Another nice memory trick to remember that the trapezium is by the thumb is that they both have the letter M. To determine if you're looking at the carpal bones from an anterior or posterior view, remember that the pisiform bone lies anterior to the triquetrum bone, so it's hidden in a posterior view. Then to identify the bones, start by looking at the lateral side, the side with the thumb on it, and locate the scaphoid bone on the proximal row of bones. Remember the scaphoid bone is large and articulates with the distal radius. From there, identify the rest using the mnemonic we just learned. Pause the video and try identifying the bones on this X-ray of the hand. Alright, the distal carpal bones articulate with the 5 bones of the hand called the metacarpals, forming the carpo-metacarpal joints. Metacarpals are numbered from 1 to 5, starting on the lateral side, which is the thumb side. The first metacarpal bone is separated from the rest, which facilitates free movement of the thumb independent of the palm. Distally, metacarpals articulate with the proximal phalanges, which are also named from 1 to 5 starting from the thumb. The contact between the metacarpals and the first row of phalanges makes the metacarpophalangeal joints, which are perceived as knuckles at the dorsum of the clenched hand. Distal to the proximal phalanges are the middle and distal phalanges. However, the thumb only has 2 phalanges, a proximal and a distal. The phalanges are connected together by interphalangeal joints. Alright, so let's take one more pause here before the recap, and try to identify the bones labeled from A to J on the following image. Alright, as a quick recap. The upper limb starts with the pectoral girdle, which has 2 bones, the scapula and the clavicle. The scapula is a triangular flat bone with the superior, the medial, and the lateral borders. On its posterior surface, there's the spine of the scapula, which becomes the acromion process laterally, which articulates with the lateral end of the clavicle, the infraspinous and the supraspinous fossae. On the anterior surface of the scapula, there's the subscapular fossa, and on the superior border, there are the suprascapular notch, the coracoid process, and the lateral-facing glenoid cavity. Medial to the lateral end of the clavicle on the inferior side is the trapezoid line, and the conoid tubercle and the subclavian groove. Finally, there's its medial end, which articulates with the manubrium of the sternum. The humerus articulates with the glenoid cavity proximally, and is composed of the humeral head, the anatomical neck, the greater and lesser tubercles, surgical neck, and the inner tubercular groove. The humeral shaft starts below the surgical neck, and it has a deltoid tuberosity, the radial groove, the medial and the lateral supracondylar ridges, and the epicondyles. Distally, the humerus has the capitulum, the trochlea, the coronoid and the radial fossae on the anterior side, and the olecranon fossa on the posterior side. The forearm has two bones, the ulna and the radius. Proximally, the ulna has the olecranon and coronoid process, trochlear and radial notches, and tuberosity of the ulna. On its shaft, it has the interosseous border and the head of the ulna and the styloid process on the distal part. The proximal radius consists of the head, the neck, and the radial tuberosity. The shaft has the interosseous border, and distally we have the ulnar notch and the dorsal tubercle. The wrist has 8 carpals, which are the scaphoid, the lunate, the triquetrum, the pisiform on the proximal row, and then the hamate, capitate, trapezoid, and trapezium on the distal row. The hand has 5 metacarpals, which are distally followed by a total of 14 phalanges of the fingers.
The upper limb contains an intricate metrosystem of blood vessels, muscles, and nerves. These structures are wrapped up and organized into different compartments by superficial and deep fascia layers, and together they form the multifunctional upper limbs we know and love. So, let's start with the fascia. You can think of fascia as a pair of thin stockings made of connective tissue that support and bind together different parts of the body, including the upper limbs. Now, each upper limb actually has 2 pairs of stockings on top of each other, the superficial fascia, which sits right underneath our skin, and the deep fascia, which is deep to or beneath the superficial fascia, and it sits on top of muscles, organizing them into compartments. In the upper limb, there are 6 fasciae to remember. We have the pectoral fascia, the clavipectoral fascia, the axillary fascia, the deltoid fascia, the brachial fascia, and antebrachial fascia. The wrist and the hand also have fibrous band-like structures called the flexor retinaculum, the extensor retinaculum, and the palmar aponeurosis. Okay, let's start with the pectoral fascia, which is a broad, thin sheath of connective tissue surrounding the pectoralis major muscle, from which it gets its name. Medially, the pectoral fascia is attached to the sternum along with the pectoralis major's origin. Superiorly, it attaches to the clavicle, and supralaterally, this fascia passes over this narrow trench called the deltopectoral groove to blend with the deltoid fascia covering the deltoid muscle around the shoulder. The deltopectoral groove serves as a passageway for the cephalic vein when it's traversing from the arm to enter the lateral aspect of the chest. Inferiorly, the pectoral fascia spreads downwards and becomes continuous with the fascia of the anterior abdominal wall, while on the lateral side, the fascia curves around the lateral border of the pectoralis major to become continuous with the axillary fascia in the floor of the axilla. Next comes the clavipectoral fascia, which is deep to the pectoral fascia and pectoralis major. Superiorly, it's attached to the clavicle. Immediately below the clavicle, the clavipectoral fascia encloses the subclavius muscle and then the pectoralis minor muscle before becoming continuous with the axillary fascia inferiorly. Between the pectoralis minor and the subclavius, there's the costocoracoid membrane, which is pierced by the lateral pectoral nerve innervating the pectoralis major, the cephalic vein, and the thoracoacromial artery. Inferior to the pectoralis minor, the fascia forms the suspensory ligament of the axilla, which supports the axillary fascia and pulls the skin up when abducting the arm, creating the axillary fossa or armpit. Unsurprisingly, the fascia covering the deltoid muscle is called the deltoid fascia. Superiorly, the deltoid fascia attaches to the clavicle, the acromion process, and the spine of the scapula. It then spreads downwards to cover the superficial surface of the deltoid muscle. Inferiorly, it merges with the pectoral fascia on the anteromedial side, the infraspinous fascia posteriorly, and the fascia of the arm distally. Alright, now let's have a look at the fascia of the arm, also called the brachial fascia. The brachial fascia is a tough connective tissue looking like the sleeve of a t-shirt, covering the muscles of the arm. Proximally, the brachial fascia is continuous with the deltoid, the axillary, and the pectoral fasciae, while distally, the brachial fascia attaches to the epicondyles of the humerus and the olecranon of the ulna and blends with the antebrachial fascia of the forearm. The brachial fascia sends medial and lateral intermuscular septa inwards to the shaft and medial and lateral supracondylar ridges of the humerus, which divide the arm into two compartments, the anterior and posterior compartments. The anterior compartment is also called the flexor compartment because it houses muscles responsible for elbow flexion, while the posterior compartment is called the extensor compartment because it houses muscles responsible for elbow extension. At its distal part, the brachial fascia is continuous with the antebrachial fascia, or just the fascia of the forearm. The antebrachial fascia surrounds the muscles of the forearm, which are divided into two compartments by an intramuscular septum and a band of fibrous connective tissue called the interosseous membrane. It's called the interosseous membrane because it connects two bones together, the radius and the ulna. The two compartments of the forearm are the posterior compartment, also called the extensor supinator compartment, as it contains muscles that extend the wrist and supinate the forearm, and the anterior or flexor pronator compartment, which contains muscles that flex the wrist and pronate the forearm. Over the posterior side of the arm, the fascia becomes thicker as it reaches the distal radius and ulna, eventually transforming into a transverse band known as the extensor retinaculum, which holds the extensor tendons in position. On the anterior side, the antebrachial fascia also forms another thick fibrous band continuous with the extensor retinaculum referred to as the palmar carpal ligament. Distal and deeper to the palmar carpal ligament lies the flexor retinaculum, which is another fibrous band that extends between the anterior prominences of the outer carpal bones. Medially, the flexor retinaculum attaches to the pisiform and the hook of the hamate, while on the lateral side it attaches to the tubercle of the scaphoid and the crest of the trapezium. Together, the flexor retinaculum and the anterior concave surface made by carpal bones form an osseofibrous tunnel called the carpal tunnel, which serves as a passageway for a nerve called the median nerve and the flexor tendons of the forearm. In the hand, the antebrachial fascia extends beyond the flexor and extensor retinacula and becomes the palmar fascia. As it enters the hand, the central part of the palmar fascia, called the palmar aponeurosis, is a thick, tendinous, and triangular structure that covers the central compartment of the palm. Proximally, the apex of this palmar aponeurosis blends with the flexor retinaculum and the tendon of the palmaris longus muscle. Moving distally, 4 longitudinal bands radiate distally from the apex of the palmar aponeurosis. At the bases of the fingers, they become continuous with the fibrous tendon sheaths of the digits. The medial border of the palmar aponeurosis becomes continuous with the hypothenar fascia, the one that covers the hypothenar muscles. On its lateral border, the palmar aponeurosis becomes continuous with the thenar fascia covering the thenar muscles. Alright, now let's pause for a minute and see if you can identify the 6 fasciae of the upper limb. And now, let's switch gears a little bit and talk about the veins of the upper limb, which can also be superficial or deep veins. The superficial veins are those which can be found in the superficial fascia and are easily accessible, for example, when you need to have a blood sample taken. Initially, the superficial veins of the upper limb start as small veins in the subcutaneous tissues from the dorsal venous network of the hand. They converge into bigger venous networks as they progress proximally up along the wrists and the forearm, resulting in big superficial veins called the cephalic vein, the basilic vein, and the median antebrachial vein, also known as the median vein of the forearm. The cephalic vein arises in the converging network of small veins from the lateral aspect of the dorsal venous network. The cephalic vein then ascends on the lateral border of the wrist and travels up the anterolateral surface of the forearm and arm and is often visible through the skin. Anterior to the elbow, the cephalic vein communicates with the median cubital vein, which passes obliquely across the cubital fossa to meet up with the basilic vein, which drains the medial side of the upper limb. The cephalic vein continues its course superiorly in the arm on the lateral side between the deltoid and pectoralis major muscles in the deltopectoral groove through the deltopectoral triangle, a triangular space bordered by the clavicle, the lateral border of the pectoralis major muscle, and the medial border of the deltoid muscle. At this level, the cephalic vein empties into the terminal part of the axillary vein after it pierces the costocoracoid membrane of the clavipectoral fascia. Similar to the cephalic vein, the basilic vein ascends in the subcutaneous tissue from the medial end of the dorsal venous network, which ascends on the medial side of the forearm and inferior part of the arm. Then, it pierces the brachial fascia to pass deep near the junction of the middle and inferior thirds of the arm, running superiorly parallel to the brachial artery, eventually merging with the deep veins accompanying the brachial artery to form the axillary vein. The median antebrachial vein is highly variable, and it usually starts at the base of the dorsum of the thumb and then ascends between the cephalic and the basilic veins territories at the anterior aspect of the forearm. It then joins the basilic vein below the cubital fossa, but in a few individuals, it can divide into a median cephalic vein draining into the cephalic vein, and a median basilic vein that drains in the basilic vein. Makes sense, right? Okay, now let's have a look at the deep veins. Unlike the superficial veins, the deep veins are located deep to the muscles, and they commonly accompany major arteries, so they're called the venae comitantes, which is Latin for accompanying veins. Just like the superficial veins, the deep veins start as a tiny network, but this time it's deep in the hand. These tiny veins then form the superficial and deep palmar venous arches. On the medial side, this network gives rise to the ulnar veins, which ascend alongside the ulnar artery on the medial side of the forearm. On the lateral side of the hand, the deep palmar venous arch gives rise to the radial veins, which climb up the forearm alongside the radial artery. Both the ulnar and the radial veins terminate in the cubital fossa, where they join to form the big deep veins of the arm, known as the brachial veins. Traveling alongside the brachial artery, the brachial veins continue up the arm where they join the basilic vein to form the axillary vein. Alright, so before we continue, let's have you take a small pause and try to identify the 3 big superficial veins and 2 deep veins of the upper limb. Now, alongside the veins run the lymphatic vessels, which are responsible for the lymphatic drainage of the upper limb. Their major function is to collect excess fluids in the extracellular space and bring it back to the venous circulation. Just like the veins, lymphatic vessels are also divided into superficial and deep lymphatic vessels. The superficial lymphatic vessels of the upper limb also start as a network of tiny lymph vessels in the skin of the hand called the lymphatic plexuses, and they converge into bigger lymph vessels that ascend the upper limb mostly alongside the cephalic and basilic veins. Some of the lymphatic vessels which travel alongside the basilic vein drain in the cubital lymph nodes. These lymph nodes are located medial to the basilic vein and proximal to the medial epicondyle of the humerus. From the cubital lymph nodes arise other lymph vessels which ascend in the arm to terminate in the humeral or lateral axillary lymph nodes. On the other hand, other lymphatic vessels on the lateral side of the forearm and the arm run alongside the cephalic vein to the proximal part of the arm. At this level, they either cross medially to enter the apical axillary lymph nodes or drain into the deltopectoral lymph nodes at the tip of the deltopectoral groove. The deep lymphatic vessels are less numerous than the superficial lymphatic vessels. But just like the superficial lymphatic vessels, the deep lymphatic vessels also follow the course of the nearby deep veins such as the ulnar, radial, and brachial veins as they ascend to terminate in the humeral or lateral axillary lymph nodes. Unlike the superficial veins, which mainly drain fluids from the subcutaneous tissue, the deep lymphatic vessels drain lymphatic fluids from structures buried deep in the body, such as the bone periosteum, tendons, joint capsules, and muscles. Okay, now let's have a look at the cutaneous innervation of the upper limb. This consists of a network of nerves that carry sensations of pain, touch, temperature, and pressure to the central nervous system. They also carry some sympathetic fibers which supply the sweat glands, small arteries in the skin, and erector pili muscles. Cutaneous nerves of the upper limb carry fibers originating from the spinal roots of the C3 to T2 spinal segments. This spinal segment can be divided into 3 parts. The first one goes from C3 to C4, and it's part of the cervical plexus, which normally extends from C1 to C4. The second goes from C5 to T1, and it forms the brachial plexus. The last part consists of the T2 spinal segment, which gives rise to the lateral cutaneous branch of the second intercostal nerve called the intercostobrachial nerve. So every spinal segment receives sensory fibers from a specific territory of the skin, and these specific areas of skin are what we call dermatomes, which we'll discuss after we describe the cutaneous innervation of the upper limb. Alright, now let's see how cutaneous innervation of the upper limb is distributed. The most proximal dermatomes are innervated by the cervical plexus via the supraclavicular nerves originating in the C3 and C4 spinal segments. The supraclavicular nerves innervate the skin at the base of the neck and extend laterally over the shoulder. The lateral aspect of the arm gets its innervation from the superior lateral cutaneous nerve of the arm, branching from the axillary nerve, and the inferior lateral cutaneous nerve of the arm, often branching from the radial nerve, both originating from the C5 and C6 spinal segments. The skin under the axilla and the upper part of the medial side of the arm get their innervation from the intercostobrachial nerve, which is T2. While the skin immediately below this level on the medial part of the arm gets its innervation from the medial cutaneous nerve of the arm, which is mainly from T1. The posterior aspect of the arm gets its innervation from the posterior cutaneous nerve of the arm, which is also a branch of the radial nerve and originates from the C5 to C8 spinal segments. The skin over the lateral side of the forearm gets its innervation from, well, you guessed it, the lateral cutaneous nerve of the forearm. This nerve is a branch of the musculocutaneous nerve, and it originates its fibers from the C5 and C6 spinal segments. The skin over the posterior side of the forearm gets its innervation from the posterior cutaneous nerve of the forearm, the branch of the radial nerve originating its fibers from the C5 to C8 spinal regions. The medial side of the forearm is supplied by the medial cutaneous nerve of the forearm, which originates its fibers from the C8 and T1 spinal segments. Initially, this nerve runs with the ulnar nerve before it perforates the deep fascia at approximately the midarm to enter the subcutaneous tissue of the forearm to innervate the skin over the medial side of the forearm. Now let's have a look at the cutaneous innervation of the hand, starting with the palm. The lateral 2/3 of the palm are innervated by the palmar cutaneous branch of the median nerve, which is C6 to C8. Still on the palm side, the medial 1/3 gets its innervation from the palmar cutaneous branch of the ulnar nerve, which is C8 and T1. Turning the hand to look at its dorsal surface, the lateral 2/3 get their innervation from the superficial terminal branch of the radial nerve, which is C6 to C8. Still on the dorsum of the hand, the medial 1/3 of the dorsum of the hand gets its innervation from the dorsal cutaneous branch of the ulnar nerve. Okay, let's now have a look at the digits. The palmar aspects of the lateral 3.5 digits, plus their dorsal distal halves, are innervated by the digital branches of the median nerve originating in the C6 to C8 spinal roots. The palmar aspects of the medial 1.5 digits, plus their dorsal distal halves, get their innervation from the palmar digital branches of the ulnar nerve, which is C8 and T1. Flipping the hand, the dorsal aspects of the proximal lateral 3.5 digits get their innervation from the digital branches of the radial nerve, which is C6 to C8. Lastly, the dorsal aspects of the proximal parts of the medial 1.5 digits get their innervation from dorsal digital branches of the ulnar nerve. Okay, now hold on. You might be thinking that this weird dermatomal arrangement of the upper limb doesn't seem to follow any pattern at all, but it's actually quite the opposite. They follow a well-defined and predictable pattern based on the embryonic origin of the upper limb. To understand this, let's hold the arms in the abducted position with all the joints extended and the thumb facing upwards. In this position, you can see that the dermatomes of the upper limb are arranged in a specific numerical sequence, where we start at the base of the neck, travel distally down the lateral or radial side of the arm, move across the digits laterally to medially, come back up the medial or ulnar side of the arm proximally, and end in the axilla. On the lateral side of the upper limb, from the shoulder to the thumb, the skin is innervated by fibers from the C3 to C6 spinal segments. From the thumb to the little finger, it's by C6 to C8, and finally, on the medial side of the arm, from the little finger to the axilla, it's by the C8 to T2 spinal segments. Like many things in anatomy, this dermatome map can vary. However, this is a general dermatomal map often used during clinical examination to test for cutaneous sensation. Switching to myotomes, these are defined as muscles that receive motor innervation from a single spinal nerve. Now, upper limb muscles usually receive motor fibers from more than one spinal cord segment or nerves, which, of course, complicates things and results in most muscles having more than one myotome. To understand the concept of myotomes, it's easier to associate certain myotomes with different movements that occur in the upper limb and then relate that to the muscle responsible for that movement. For example, the myotomes for the movement of elbow flexion are both the C5 and C6 myotomes. This makes sense because elbow flexion is carried out by the brachialis and biceps brachii muscles, which are innervated by the musculocutaneous nerve. Elbow flexion, having the C5 and C6 myotomes, is derived from the fact that the musculocutaneous nerve originates from the C5 to C7 nerve roots, where the C5 and C6 portions are responsible for elbow flexion. By knowing which muscles cause movements of the upper limb, we can figure out the myotomes of those movements, which ultimately can be tested clinically to help determine nerve dysfunction. Let's take a closer look at the myotomes that govern the rest of the movements of the upper limb. Glenohumeral lateral rotation is myotome C5, and medial rotation are myotomes C6 to C8. Glenohumeral abduction is C5, and adduction is C6 to C8. Glenohumeral flexion is C5, and extension is C6 to C8. Moving on to the elbow joint, elbow flexion is C5, C6, and elbow extension is C6, C7. Forearm supination is C6, and pronation is C7, C8. At the wrist joint, both extension and flexion is C6, C7. Finally, at the hand, digit flexion and extension are C7, C8, where digit abduction and adduction are controlled by T1. Okay, here's one last pause before we recap. Can you recall the cutaneous innervation of the upper limb from an anterior view? Alright, as a quick recap. In the pectoral region, there's the pectoral fascia, which envelops the pectoralis major muscle, the clavipectoral fascia, enveloping the subclavius and the pectoralis minor muscle, and the axillary fascia, which forms the dome of the armpit. In the shoulder region, there's the deltoid fascia, which covers the deltoid muscle. Distally, there's the brachial fascia, which encloses the muscles of the arm and divides them into the anterior and posterior compartments by its intermuscular septa. In the forearm, there's the antebrachial fascia, which envelops the muscles of the forearm and divides them into an anterior and posterior compartment thanks to the intermuscular septum and the interosseous membrane. The major superficial veins of the upper limb are the cephalic vein that drains the lateral side of the limb, the basilic vein that drains the medial side, and the median antebrachial vein which drains the middle anterior part of the forearm. Regarding the deep veins, on the other hand, the ulnar and radial veins drain into the brachial veins, which ultimately drain into the axillary vein. Now, regarding lymphatics, in the forearm, the lymphatic vessels drain into the cubital lymph nodes on the medial side of the forearm before continuing in the arm to terminate in the lateral axillary lymph nodes. Laterally, the lymph vessels climb up to the proximal part of the arm to either cross medially and enter the apical axillary lymph nodes, or continue to ascend to terminate in the deltopectoral lymph nodes. Finally, the cutaneous innervation of the upper limb comes from spinal roots C3 to T2 and derives from the cervical plexus, the brachial plexus, and the T2 spinal segment. Regarding the dermatomes, on the lateral side of the upper limb, from the shoulder to the thumb, the skin is innervated by fibers from the C3 to C6 spinal segments. From the thumb to the little finger, it's by C6 to C8, and finally, on the medial side of the arm, from the little finger to the axilla, it's by the C8 to T2 spinal segments. Regarding the myotomes, glenohumeral lateral rotation is myotome C5, and medial rotation is C6 to C8. Glenohumeral abduction is C5, and adduction is C6 to C8. Glenohumeral flexion is C5, and extension is C6 to C8. Moving on to the elbow joint, elbow flexion is C5, C6, and elbow extension is C6, C7. Forearm supination is C6, and pronation is C7, C8. At the wrist joint, both extension and flexion is C6, C7. Finally, at the hand, digit flexion and extension are C7, C8, where digit abduction and adduction are controlled by T1.
The wrist is a complex joint that serves as the bridge connecting the forearm and the hand together. It consists of a main radiocarpal joint between the radius and the proximal row of the carpal bones minus the pisiform, and the smaller intercarpal joints, which are small joints among the carpals. Then we have the hand, which consists of the carpometacarpal joints, the intermetacarpal joints, the metacarpophalangeal joints, and the interphalangeal joints. Try saying those 3 times fast. Okay, let's start with the wrist joint. First, there's the radiocarpal joint, which is a condyloid type of synovial joint consisting of the distal radius and scaphoid, the lunate, and the triquetrum carpal bones. Interestingly enough, the ulna doesn't participate in the radiocarpal joint. It is the articulating surface of the distal radius and the articular disc of the distal radio-ulnar joint, which articulate with the proximal row of carpal bones to form the radiocarpal joint. The articulating surfaces of the radiocarpal joint are surrounded by the tough joint capsule and synovial membrane, extending from the distal ends of the radius and ulna to the scaphoid, the lunate, and the triquetrum. The joint capsule of the radiocarpal joint is reinforced by a couple of ligaments, both on the dorsal and the palmar sides of the joint. The palmar ligaments extend from the distal radius to the 2 rows of the carpal bones. These ligaments strengthen the joint and make it possible for the hand and the radius to move as one unit during supination of the forearm, or turning the palm upwards. To remember this, think about cupping both your hands and bringing them together to hold a bowl of soup, which mimics the movement of supination. On the posterior side of the radiocarpal joint, there are the dorsal radiocarpal ligaments, which also extend from the distal radius to the carpal bones. These ligaments stabilize the wrist joint and ensure that the hand follows the radius during pronation of the forearm or the turning of the palm downwards. Other ligaments that strengthen the radiocarpal joint are the ulnar collateral ligament on the medial side, which extends from the ulnar styloid process to the triquetrum, and the radial collateral ligament on the lateral side, extending from the radial styloid process to the scaphoid bone. Now, a couple of muscles act on the radiocarpal joint. They're easy to remember because they all attach to the carpals distally and they have carpi in their names. So, there's the flexor carpi radialis and the flexor carpi ulnaris, which flex the wrist, the extensor carpi radialis longus, the extensor carpi radialis brevis, and the extensor carpi ulnaris, which extend the wrist, the abductor pollicis longus, the flexor carpi radialis, the extensor carpi radialis longus, and the extensor carpi radialis brevis, which abduct or radially deviate the wrist, and then finally, the extensor carpi ulnaris and the flexor carpi ulnaris muscles, which adduct or ulnar deviate the wrist. Now, the radiocarpal joint receives its blood supply from the dorsal and palmar carpal arches, originating from the radial and ulnar arteries. Regarding innervation, remember Hilton's law, which says the nerves that innervate the muscles crossing over a particular joint also innervate that joint. So according to Hilton's law, the radiocarpal joint is innervated by branches of the median, ulnar, and radial nerve. Now let's look at the intercarpal joints, which are the small joints between the carpal bones. They can be put into 4 groups to make things simple. There are joints between the carpal bones of the proximal row, the joints between the carpal bones of the distal row, the midcarpal joint between the proximal and distal rows of carpal bones, and the pisotriquetral joint located between the pisiform and the palmar surface of the triquetrum. All of these joints are the plane type of synovial joint limited to the gliding movements between the carpals. Though this sounds like a minor role, these joints are important because their combined little movements augment the range of motion of the radiocarpal joint. Sometimes less is more. Now, after the distal row of carpal bones, there are the long metacarpals, which form carpometacarpal joints with the carpals and intermetacarpal joints among themselves. The first carpometacarpal joint is responsible for the movements of the thumb and consists of the trapezium and the first metacarpal bone, which is the only saddle type of synovial joint of the carpometacarpal joints. The other 4 carpometacarpal joints are plane type synovial joints formed by the articulations between metacarpals 2 through 5 and the distal row of the carpal bones. The thumb's carpometacarpal joint is a much more mobile joint, so it allows for flexion and extension, abduction and adduction, and circumduction. It also allows for some axial rotation, which is essential to the movement of thumb opposition. Distal to the metacarpals, there are the phalanges, which are the bones of the fingers. All the fingers except for the thumb have 3 phalanges, a proximal, middle, and distal one, while the thumb only has a proximal and distal phalange. The phalanges form metacarpal phalangeal joints between them and the metacarpals, and interphalangeal joints between the proximal phalanges and the middle or distal phalanges. They also inspired a certain Friends character to change her name to Regina Phalange. Bonus points if you can remember who that was. Okay, now on a more serious note, in the metacarpal phalangeal joints, which are the condyloid type of synovial joint, the heads of the metacarpals articulate with the bases of the proximal phalanges, and there are synovial membranes surrounded by a joint capsule for each joint. The metacarpal phalangeal joints permit adduction and abduction movements, like when spreading your fingers apart to make a peace sign, and also flexion and extension, which happens when you clench and unclench your fingers at the level of the knuckles. The interphalangeal joints, on the other hand, are the hinge type of synovial joint, so they only allow for flexion and extension, like when you're signaling someone to come over with your index finger. Now there are three important muscles that flex the metacarpophalangeal and interphalangeal joints. First, there is the flexor digitorum superficialis, which flexes the proximal and the middle phalanges at the metacarpophalangeal and proximal interphalangeal joints of the medial 4 digits due to its tendon insertions on the shafts of the middle phalanges. The flexion of the distal phalanges at the distal interphalangeal joint of the medial 4 digits is done by the flexor digitorum profundus, due to its tendon insertions on the base of the distal phalanges. Both the proximal and distal phalanges of the thumb are flexed by the flexor pollicis longus, acting on both the metacarpophalangeal and the interphalangeal joints. Just one pause because we hit the recap. Can you name the bones involved in the radiocarpal joint? Alright, as a quick recap, the wrist joint connects the hand to the forearm. It is a condyloid type of synovial joint located between the distal end of the radius and the proximal row of the carpal bones except for the pisiform. It can perform flexion, extension, abduction, and adduction. The intercarpal joints are all the plane type of synovial joints, limited to only gliding movements between the carpals. Distal to the carpals, there are the carpometacarpal joints connecting the metacarpals to the distal row of the carpals. They are all the plane type of synovial joint, except the first carpometacarpal joint, also known as the thumb, which is a saddle type. Only the first carpometacarpal joint is a mobile joint, allowing for flexion and extension, abduction and adduction, circumduction and axial rotation to allow opposition. Metacarpals connect to each other via intermetacarpal joints and to the row of the proximal phalanges via the metacarpophalangeal joints. The metacarpophalangeal joints are the condyloid type of synovial joints, and they allow for adduction and abduction, as well as flexion and extension. Finally, the interphalangeal joints connect the phalanges together. In the medial 4 digits, there are 2 rows of interphalangeal joints, while in the thumb, there's only 1. Interphalangeal joints are a hinge type of synovial joint, allowing only for flexion and extension.
Anatomically speaking, the forearm is the part of the upper limb between the elbow and the wrist joints. It contains 2 bones, the ulna and the radius, which provide support to local muscles supplied by an intricate network of nerves and vessels. On the anterior part of the elbow, there's a triangular fat-filled pit called the cubital fossa, which is where the majority of important nerves and vessels to the forearm and hand can be found. Okay, before we start, it's important to know that even though some of the muscles of the forearm attach proximally to the humerus, they still belong to the forearm. The forearm is divided into 2 compartments, which are separated by the radius and the ulna, and the interosseous membrane running between them. We have the anterior compartment, which contains flexors and pronators. Next is the posterior compartment, housing the extensors and supinators of the forearm. Generally, muscles in the same compartment are innervated by the same nerve. So the muscles of the anterior compartment are generally innervated by the median nerve, with a few muscles being innervated by the ulnar nerve. Muscles of the posterior compartment, on the other hand, are innervated by the radial nerve. Now, the muscles of the anterior compartment are divided into 3 groups, or layers: superficial, intermediate, and deep. In the superficial layer, there are 4 muscles which all arise from a common tendon attached to the medial epicondyle of the humerus. So this attachment site is called the common flexor origin. Muscles attaching to the common flexor origin are the flexor carpi ulnaris, the palmaris longus, the flexor carpi radialis, and the pronator teres muscles. Now, let's look at these muscles one by one. On the most medial side lies the flexor carpi ulnaris. This muscle has 2 heads, the humeral head that proximally attaches to the medial epicondyle of the humerus, and the ulnar head proximally attaching to the olecranon and the posterior border of the ulna. As these 2 move distally to the wrist, they fuse into one tendon that crosses the wrist to distally attach to 3 bones, the pisiform, the hook of hamate, and 5th metacarpal bone. Although muscles of the superficial layer are primarily innervated by the median nerve, the flexor carpi ulnaris muscle is an exception because it is fully innervated by the ulnar nerve. This muscle mainly flexes and adducts the hand at the wrist joint. Lateral to the flexor carpi ulnaris, there is the palmaris longus muscle. This muscle proximally attaches to the medial epicondyle of the humerus and extends distally to form a tendon that attaches to the distal half of the flexor retinaculum and the apex of the palmar aponeurosis. The palmaris longus muscle is innervated by the median nerve. When it contracts, it flexes the hand at the wrist. A little fun fact about the palmaris longus, it is absent in about 14% of people, but luckily, its absence doesn't come with any functional deficits. Lateral to the palmaris longus, there's the flexor carpi radialis muscle, which also proximally attaches to the medial epicondyle of the humerus. It extends distally and laterally to the middle of the forearm, forming a tendon that attaches at the base of the 2nd metacarpal bone. The flexor carpi radialis is innervated by the median nerve. When it contracts, it flexes and abducts the hand at the wrist joint. Finally, there's the pronator teres, which is the most lateral muscle of the superficial muscles in the anterior compartment. It also has a humeral and an ulnar head. Proximally, the humeral head attaches to the medial humeral epicondyle, while the ulnar head attaches to the coronoid process of the ulna. As the muscle extends distally, its 2 heads fuse into one tendon that attaches to the midshaft of the radius on its lateral aspect. The pronator teres is innervated by the median nerve, and its contraction pronates and flexes the forearm at the elbow. Okay, now what if we take a 1-minute pause to just flex your wrists? At the same time, try to remember the muscles that attach to the common flexor origin Now, let's have a look at the intermediate layer of the anterior compartment of the forearm. It's a one-muscle compartment containing only the flexor digitorum superficialis. This muscle has 2 heads, a humero-ulnar head that attaches to the common flexor origin and the coronoid process, and a radial head that attaches to the superior half of the anterior border of the radius, also called the anterior oblique line. Moving distally, the 2 heads of the flexor digitorum superficialis fuse together in the middle of the forearm, and that eventually splits into 4 separate tendons at the level of the wrist. All of these tendons pass deep to the flexor retinaculum in the carpal tunnel, eventually attaching to the shafts of the middle phalanges of the medial 4 digits. The flexor digitorum superficialis is innervated by the median nerve, and its actions depend on how hard it's contracting. When it contracts moderately, it flexes the middle phalanges at proximal interphalangeal joints of the medial 4 digits. With a stronger contraction, this muscle flexes the proximal phalanges at the metacarpal phalangeal joints. Finally, let's look at the 3 muscles of the deep layer of the anterior compartment of the forearm, the flexor digitorum profundus, the flexor pollicis longus, and the pronator quadratus. The flexor digitorum profundus has 2 proximal parts, a medial and a lateral part, and both of them attach to the proximal 3/4 of the anterior aspect of the ulna and the interosseous membrane. Distally, the medial part splits into 2 tendons to attach to the base of the 4th and 5th distal phalanges, and the lateral part splits into 2 tendons to attach to the bases of the 2nd and 3rd distal phalanges. All the tendons pass posterior to the flexor digitorum superficialis and flexor retinaculum. The medial part functions to flex the distal phalanges of digit 4 and 5 and the distal interphalangeal joints, while the lateral part does the same thing for the second and third digits. An important distinction here is that the lateral part is innervated by the anterior interosseous nerve, a branch of the median nerve, while the medial part is actually innervated by the ulnar nerve along with the flexor carpi ulnaris. To easily remember this, think of how the flexor carpi ulnaris and the medial part of the flexor digitorum profundus are both medial and are closer to the ulnar side of the forearm. This will remind you that they are innervated by the ulnar nerve as it travels more medially in the forearm as well. Next up, there's the flexor pollicis longus, which attaches proximally to the anterior surface of the radius and interosseous membrane. As the flexor pollicis longus extends distally, it transforms into a flat tendon that passes under the flexor retinaculum of the hand through the carpal tunnel to insert to the base of the distal phalanx of the thumb. The flexor pollicis longus is innervated by the anterior interosseous nerve, which is a branch of the median nerve, and it causes flexion of the thumb. Finally, there's the pronator quadratus muscle, which is a quadrangular muscle found deep to the other muscles in the anterior compartment. Proximally, it attaches to the distal quarter of the anterior surface of the ulna, and it extends laterally and distally to attach to the distal quarter of the anterior surface of the radius. The pronator quadratus is innervated by the anterior interosseous branch of the median nerve. When it contracts, it is the primary pronator of the forearm, while also helping to hold the radius and ulna together. Now, it's also important to know that the majority of these flexor tendons from the anterior compartment are held in place to prevent bowing by both the palmar carpal ligament and the distal and deeper flexor retinaculum, which is also known as the flexor retinaculum. Both of these can be found on the anterior surface of the hand and wrist. Furthermore, a lot of these tendons are enclosed in either common synovial sheaths or individual synovial sheaths, which allow the tendons to slide freely over each other during movements. Okay, let's take another pause here and see if you can remember the only muscle of the intermediate layer and the 3 muscles in the deep layer of the anterior compartment. So let's now move to the posterior compartment of the forearm. The muscles of the posterior compartment are all innervated by the radial nerve, and they're mainly extensors of the wrist and digits. In a similar fashion to the flexor muscle tendons, the extensor muscle tendons are held in place posteriorly by the extensor retinaculum, which is this thickened part of fascia on the posterior aspect of the wrist to prevent bowing of the tendons. The extensor tendons also have synovial tendon sheaths to reduce friction during movement. The posterior compartment muscles are divided into a superficial and deep layer. The superficial layer has 6 muscles: the brachioradialis, the extensor carpi radialis longus, the extensor carpi radialis brevis, the extensor digitorum, the extensor digiti minimi, and the extensor carpi ulnaris muscle. The brachioradialis is the most lateral muscle in the superficial layer. Although it is anatomically grouped in as an extensor muscle of the posterior compartment due to its location, the brachioradialis is functionally counted as a flexor because it is a weak flexor of the forearm. Its proximal broad part attaches to the proximal 2/3 of the lateral supraepicondylar ridge of the humerus, and then narrows down as it extends distally to attach to the lateral surface of the distal radius, proximal to the styloid process. When it contracts, it flexes the forearm, especially if it was in a mid-pronated position. This muscle is also known as the beer drinking muscle because it gets a real workout when you drink a can of beer. The second muscle is the extensor carpi radialis longus. Its name itself, the extensor carpi radialis longus, implies that it's a long muscle that runs alongside the radial bone and that it extends the wrist. So it attaches proximally from the lateral supraepicondylar ridge of the humerus and crosses the wrist to attach to the base of the second metacarpal bone. When it contracts, it extends and abducts the hand at the wrist joint. Next up, there are 4 muscles which have a common proximal attachment: the extensor carpi radialis brevis, the extensor digitorum, the extensor digiti minimi, and the extensor carpi ulnaris. They all attach to the lateral epicondyle of the humerus, so this is the common extensor origin. In the distal forearm, the extensor carpi radialis brevis crosses the wrist and attaches to the base of the third metacarpal bone. It functions in the same way as the extensor carpi radialis longus, to extend and abduct the wrist. The extensor digitorum occupies most of the posterior surface of the forearm, and from its attachment to the lateral epicondyle, it eventually splits into 4 tendons and travels deep to the extensor retinaculum. These tendons pass deep to the retinaculum and then spread as they move along the dorsum of the hand, where they attach to the extensor expansions of the medial 4 digits. The extensor expansions wrap around the dorsum and sides of the metacarpal head and proximal phalanx, forming a hood and keeping the extensor tendon in the middle of each digit. This muscle acts to extend the medial 4 digits at both the metacarpophalangeal and interphalangeal joints. Now, as the extensor digiti minimi extends distally, it forms a tendon that also passes deep to the extensor retinaculum, but in a separate compartment. In the hand, it ends up attaching in the extensor expansion of the 5th digit and extends the 5th digit, both the metacarpophalangeal and interphalangeal joints. The 6th and final muscle in the superficial layer of the posterior compartment is the extensor carpi ulnaris muscle. It also attaches to the lateral epicondyle of the humerus as well as the posterior border of the ulna, and then extends distally in the forearm, forming a tendon that crosses the wrist to attach to the base of the 5th metacarpal bone. Its function is to extend and adduct the hand at the wrist joint. The extensor carpi radialis brevis, extensor digitorum, the extensor digiti minimi, and the extensor carpi ulnaris are all innervated by the deep branch of the radial nerve, which is a distal branch of the radial nerve. Now, let's switch gears and look at the deep layer of the posterior compartment. It contains 5 muscles: the supinator, the abductor pollicis longus, the extensor pollicis brevis, the extensor pollicis longus, and the extensor indices. The abductor pollicis longus and the extensor pollicis brevis and longus are referred to as the outcropping muscles of the deep layer because they emerge or crop out in a small trench that separates the extensors in the lateral forearm. First, the supinator lies deep in the cubital fossa, forming part of its floor. It's a broad muscle with proximal attachment spanning across the lateral epicondyle of the humerus, the supinator crest, and fossa of the ulna, the radial collateral ligament, and the annular ligament. It then spirals medially and distally to broadly attach to the lateral, posterior, and anterior surfaces of the proximal third of the radius. It is innervated by the deep branch of the radial nerve, and its contraction supinates the forearm by externally rotating the radius. Alright, now let's move on to a group of 3 muscles referred to as the outcropping muscles of the deep layer. These 3 muscles are all innervated by the posterior interosseous nerve, the continuation of the deep branch of the radial nerve. The first outcropping muscle is the abductor pollicis longus, the most lateral of the 3 muscles. It proximally attaches to the upper halves of the ulna and radius, plus the interosseous membrane. It then attaches to the base of the first metacarpal bone. When the abductor pollicis longus contracts, it abducts the thumb and extends it at its carpometacarpal joint. Next, there is the extensor pollicis brevis muscle, which runs closely beside the abductor pollicis longus. It proximally attaches to the distal third of the radius and the interosseous membrane. It then attaches at the base of the proximal phalanx of the thumb. When this muscle contracts, it extends the proximal phalanx of the thumb. Next, there's the extensor pollicis longus. Its proximal attachment is to the middle third of the ulna and the interosseous membrane. It then attaches to the base of the thumb's distal phalanx after it crosses medial to the dorsal tubercle of the radius to create space between it and the extensor pollicis brevis. When the extensor pollicis longus contracts, it extends the thumb at each of its joints, including the interphalangeal joint. Finally, there is the extensor indicis muscle. The proximal attachment of this muscle is to the posterior surface of the distal third of the ulna and interosseous membrane. At the wrist, the extensor indicis forms a tendon that crosses the joint to attach to the extensor expansion of the second digit, aka the index finger. The extensor indicis muscle is innervated by the posterior interosseous nerve, which is the continuation of the deep branch of the radial nerve. When this muscle contracts, it extends the index finger and has a minor role in extending the wrist. Now, back to the outcropping muscles. As the tendons of the extensor pollicis longus and the extensor pollicis brevis cross the wrist to their attachment points, the gap between them forms a triangular-shaped depression over the trapezium and scaphoid bones. This depression is often referred to as the anatomical snuff box. The abductor pollicis longus and the extensor pollicis brevis makes the anterior boundary of the anatomical snuff box, while the extensor pollicis longus makes the posterior border. To remember the anterior boundary, think of the B in extensor pollicis brevis being a buddy to the abductor pollicis longus, where the extensor pollicis longus on its own forms the posterior boundary. You can also think of it as a brevis sandwich between the two longus muscles. Brevis sandwich. But anyway, the anatomical snuff box can be seen when the thumb is fully extended. And it's an important landmark because the radial artery can be palpated against the floor of the snuff box, which is made up by the trapezium and the scaphoid bones. Now for a quick break. Can you remember the muscles of the superficial layer of the posterior compartment? Alright, as a quick recap. The anterior compartment of the forearm has 8 muscles divided into a superficial, intermediate, and deep layer. There are 4 muscles in the superficial layer: the pronator teres, the flexor carpi radialis, the palmaris longus, and the flexor carpi ulnaris. In the intermediate layer, there is only 1 muscle, the flexor digitorum superficialis. In the deep layer, there are 3 muscles, the flexor digitorum profundus, the flexor pollicis longus, and the pronator quadratus. In the posterior compartment, there are 11 muscles divided into a superficial and deep layer. The superficial layer has 6 muscles, the brachioradialis, the extensor carpi radialis longus and the extensor carpi radialis brevis, the extensor digitorum, the extensor digiti minimi, and the extensor carpi ulnaris. In the deep layer, there are 5 muscles, the supinator, the 3 outcropping muscles, which are the abductor pollicis longus, the extensor pollicis brevis, and the extensor pollicis longus, and last but not least, the extensor indices. Finally, the anatomical snuff box is a superficial landmark on the posterolateral wrist, of which the abductor pollicis longus and the extensor pollicis brevis make the anterior boundary, while the extensor pollicis longus makes the posterior border.
The hands are the most distal part of our upper limbs, and they're quite marvelous. They're strong enough to lift heavy boxes, and at the same time delicate and precise enough to thread a needle or type on a keyboard. The diverse range of movements our hands are capable of is made possible by a variety of muscles and their arrangement within the hand. The hand is composed of intrinsic muscles, which are entirely located within the hand, and extrinsic muscles, which are forearm muscles but act on the hand and fingers through their long tendons. The intrinsic muscles of the hand are covered by the fibrous palmar fascia, which divides them into 4 main compartments. The thenar compartment, located below the first digit, known as the thumb, the hypothenar compartment, located below the 5th digit, also known as the little finger, the adductor compartment, located in the lateral part of the hand, and finally the central compartment that's found in the center of the palm. There are also several interosseous compartments between the metacarpals. The palmar fascia, which is the continuation of the antebrachial fascia in the forearm, forms the palmar aponeurosis centrally. The palmar aponeurosis is a strong, thickened portion of the palmar fascia covering the central compartment and overlies the flexor tendons. Proximally, the palmar aponeurosis blends with the tendon of palmaris longus and the flexor retinaculum, which, if you remember, is a transverse ligament spanning over the carpal bones, creating the carpal tunnel. Distally, the palmar aponeurosis divides into 4 longitudinal bands that radiate distally to attach to the bases of the proximal phalanges, where they become continuous with the fibrous digital sheaths which enclose flexor tendons going to the digits. Within the hand, the medial border of the palmar aponeurosis becomes continuous with the thin hypothenar fascia, which covers the muscles of the hypothenar compartment. The palmar aponeurosis extends laterally, where it continues with the thin thenar fascia, which covers the muscles of the thenar compartment. Now, deep to the flexor tendons, there are 2 potential spaces, the thenar space and the mid-palmar space. These spaces are important, as they are potential closed-off spaces that can become affected during a pathologic process like an infection. The thenar space underlies the thenar compartment and is located anterior to the adductor pollicis muscle, deep to the central and thenar compartments, while the mid-palmar space is deep to the central compartment of the palm and anterior to the deep hand muscles and the 3rd, 4th, and the 5th metacarpal bones. Before we take a look at the muscles of the hand, let's take a quick look at some of the movements of the hand, particularly the thumb. The thenar muscles are mainly responsible for the various movements of our thumb. The thumb can undergo flexion and extension, and these movements are in the same plane as the palm, abduction and adduction, where the movement is in a plane perpendicular to the palm, and finally, opposition and reposition, where the tip of the thumb can come in contact with the tip of the 5th digit. Now, let's take a look at each of the muscle compartments of the hand, starting with the thenar compartment. The thenar compartment is located in the lateral part of the palm and forms the thenar eminence of the hand. It contains 3 muscles which mainly act on the thumb. These are the abductor pollicis brevis, the flexor pollicis brevis, and the opponens pollicis muscle. The abductor pollicis brevis makes up the lateral part of the compartment. This muscle attaches proximally to the flexor retinaculum and the tubercles of the scaphoid and the trapezium, and then extends distally to attach to the lateral base of the proximal phalanx of the thumb. The abductor pollicis brevis is innervated by the recurrent branch of the median nerve, and when it contracts, it abducts the thumb and also assists in opposition. Next up, there's the flexor pollicis brevis, which is medial to the abductor pollicis brevis. The flexor pollicis brevis has a superficial and a deep head. Both heads attach proximally to the flexor retinaculum and the tubercles of the scaphoid and trapezium, and fuse distally to form a single tendon with a sesamoid bone within it, which attaches to the lateral base of the proximal phalanx of the thumb. The superficial head of the flexor pollicis brevis is innervated by the recurrent branch of the median nerve, while the deep head receives its innervation from the deep branch of the ulnar nerve. When they contract, they both flex the thumb. Finally, there is the opponens pollicis, which lies deep to the abductor pollicis brevis. This muscle also originates on the flexor retinaculum and tubercles of the scaphoid and trapezium, and it extends distally to attach to the lateral side of the shaft of the 1st metacarpal. The opponens pollicis receives its innervation from the recurrent branch of the median nerve, and it opposes the thumb by pulling the 1st metacarpal medially towards the 5th digit. Alright, next is the adductor compartment, which is located below the thenar muscles. This compartment has only one muscle, called the adductor pollicis. The adductor pollicis muscle also has 2 heads, an oblique head and a transverse head. The oblique head attaches to the base of the 2nd and the 3rd metacarpals, as well as the capitate carpal bone. The proximal attachment of the transverse head is to the anterior shaft of the 3rd metacarpal. Distally, both heads of this muscle form a single tendon, which contains a sesamoid bone within it and attaches to the medial base of the proximal phalanx of the thumb. The adductor pollicis is innervated by the deep branch of the ulnar nerve, and when it contracts, it adducts the thumb. Now, besides abduction, adduction, flexion, and opposition, the thumb can also perform movements such as reposition, which is moving the thumb in the opposite direction to the opposition, and extension. Thumb reposition is done by the extensor pollicis longus muscle. In order for extension to happen, the extensor pollicis brevis, the extensor pollicis longus, and the abductor pollicis longus work together. Now, before we move on, feel free to pause and see if you remember the nerve to the deep head of the flexor pollicis brevis. Alright, now let's look at the muscles of the hypothenar compartment. The hypothenar compartment also consists of 3 muscles, which move the little finger. Inside the hypothenar compartment, we have the abductor digiti minimi, which attaches to the pisiform carpal bone proximally and extends distally to attach to the base of the proximal phalanx of the little finger. This muscle mainly abducts the 5th digit. There is also the flexor digiti minimi brevis, which proximally attaches to the hook of the hamate, as well as the flexor retinaculum. Distally, the flexor digiti minimi brevis also attaches to the base of the proximal phalanx of the little finger, and obviously it flexes the 5th digit. Finally, there is the opponens digiti minimi, which attaches proximally to the hook of hamate and the flexor retinaculum, just like the flexor digiti minimi brevis. The opponens digiti minimi extends distally and attaches to the 5th metacarpal. It pulls the metacarpal towards the thumb, helping to oppose the 5th digit. All 3 muscles of the hypothenar compartment share a common innervation, which is the deep branch of the ulnar nerve. Now, outside the hypothenar compartment, just superficial to it, there's another muscle called the palmaris brevis. Proximally, the palmaris brevis attaches to the palmar aponeurosis, and distally, it attaches to the dermis of the skin of the hypothenar eminence. This muscle is innervated by the superficial branch of the ulnar nerve, and when it contracts, that tightens the palmar aponeurosis to wrinkle skin of the hypothenar eminence. This helps form a stronger palmar grip, like when holding onto the rope during tug-of-war. Finally, there are what are called the short muscles of the hand, the lumbricals and interossei. The lumbricals attach to forearm flexor tendons, so they are found within the central compartment of the hand, which is located between the thenar and the hypothenar compartments. The interossei are located between the metacarpals, which can be called interosseous compartments. Now, there are 4 lumbricals, which attach proximally to the tendons of the flexor digitorum profundus muscle. The first and the second lumbricals have 1 head each, so they're unipennate muscles, while the third and the fourth ones have 2 heads each, which makes them bipennate muscles. The proximal attachment of the first and the second lumbricals is to the 2 lateral tendons of the flexor digitorum profundus, while the 2 medial lumbricals attach to the medial 3 tendons. Distally, all 4 lumbricals attach to the lateral sides of the extensor expansions of the 2nd to the 5th digits. Extensor expansions are hood-like aponeuroses formed by the extensor tendons as they insert onto the phalanges and serve as attachment points for muscles such as the lumbricals and interossei. The first and the second lumbricals are innervated by the median nerve, while the third and the fourth lumbricals are innervated by the deep branch of the ulnar nerve. All 4 lumbricals flex the metacarpophalangeal joints, and they also extend the interphalangeal joints of the 2nd to the 5th digits. This mixture of proximal flexion and distal extension creates the bi-bi motion, showcasing the action of the lumbricals. And then we have the interosseous muscles, or interossei. There are 4 dorsal interossei and 3 palmar interossei. Before we move on, a good mnemonic to remember these muscles and their actions is DAB and PAD. DAB stands for dorsal interossei abducting the digits, and PAD stands for the palmar interossei adducting the digits. Remember that abduction and adduction of the fingers are in reference to the axial line of the hand that passes through the third digit. Let's take a closer look at the 4 dorsal interossei located on the dorsal aspect of the hand between the metacarpals. Proximally, they attach to the adjacent sides of the 5 metacarpals. For example, the first dorsal interosseous attaches proximally to the adjacent sides of digit 1 and 2. Distally, the dorsal interossei attach to the bases of the proximal phalanges along with the extensor expansions of digits 2 to 4. The first and second interossei attach to the lateral sides of the bases of the second and the third proximal phalanges respectively, while the third and the fourth dorsal interossei attach to the medial sides of the bases of the third and fourth proximal phalanges. If you notice, the second and third dorsal interossei both attach to the third digit on opposite sides to abduct it either to the left or to the right. And then there are 3 palmar interossei, which are located on the palmar side of the hand. The proximal attachment of the first palmar interosseous is along the medial part of the second metacarpal, while the second and third palmar interossei attach to the lateral parts of the fourth and the fifth metacarpals, respectively. Distally, the first palmar interosseous muscle attaches to the medial part of the second proximal phalanx, while the remaining 2 palmar interossei attach to the lateral parts of the bases of their respective proximal phalanges, while also attaching to the extensor expansions of digits 2, 4, and 5. In addition to adducting and abducting the digits, when all the interossei act together, they help the lumbricals flex the metacarpophalangeal joints and extend the interphalangeal joints. Remember, this looks like the bye-bye movement. Both the dorsal and the palmar interossei have a common innervation, which is the deep branch of the ulnar nerve. Okay. What if before we recap everything, we press the pause button and try to remember the function of the palmar interossei as opposed to the dorsal interossei? Alright, as a quick recap, the major muscle compartments of the hand are the thenar compartment, which has the flexor pollicis brevis, the abductor pollicis brevis, and the apponens pollicis, the hypothenar compartment, which has the abductor digiti minimi, the flexor digiti minimi brevis, and the apponens digiti minimi, the adductor compartment, which only contains the adductor pollicis, the central compartment, which contains the 4 lumbricals, and finally, in the interosseous compartments, there are 7 interossei. Each set of muscles is very important for the different movements of our hands. The muscles of the thenar compartment allow for flexion, abduction, and opposition of the thumb, while the adductor pollicis permits adduction of the thumb. The hypothenar compartment allows for flexion, abduction, and opposition of the 5th digit. The lumbricals act on digits 2 to 5 and allow for flexion of the metacarpophalangeal joints and extension of the interphalangeal joints, while the dorsal interossei abduct digits 2, 3, and 4, and the palmar interossei adduct digits 2, 4, and 5. The forearm contains a vast network of vessels and nerves. Most of these originate in the axilla, and to get to the forearm, most of them pass through the cubital fossa, which is a small, triangular, fat-filled pit on the anterior part of the elbow. The cubital fossa has 3 borders. The superior border consists of an imaginary line joining the medial and lateral epicondyles of the humerus. The lateral border is the medial border of the brachioradialis muscle, and the medial border is made up by the lateral border of the pronator teres muscle. Deep within this region is the floor of the cubital fossa, which is formed by 2 muscles, the brachialis and supinator. Superficially, there's the roof, which is formed by the antebrachial fascia and reinforced by the bicipital aponeurosis coming from the biceps brachii, as well as the overlying subcutaneous tissue and skin. The cubital fossa contains some important structures. From medial to lateral, there are the median nerve, the brachial artery, which bifurcates into the radial artery laterally and the ulnar artery medially, the accompanying veins to these deep arteries, the tendon of the biceps brachii muscle, and radial nerve on the most lateral part found between the brachioradialis and brachialis muscles. Overlying the brachial artery and median nerve is the bicipital aponeurosis, which protects these structures in situations like when blood is drawn from superficial veins such as the median cubital vein, which lies superficial to the bicipital aponeurosis. So that's the cubital fossa, short and sweet. Okay, now let's see some details about the arteries of the forearm. The main arteries are the ulnar and radial artery, which are the terminal branches of the brachial artery arising in the cubital fossa. Starting with the ulnar artery, it emerges from the brachial artery in the cubital fossa. The ulnar artery runs deep to the superficial and intermediate flexor muscle groups to reach the medial side of the forearm, passing superficial to the flexor retinaculum and travels through Guyon's canal to enter the hand. Along its course, the ulnar artery gives off 5 major direct branches. Immediately distal to the elbow, the ulnar artery gives its first 2 branches, the anterior and posterior ulnar recurrent artery, which both contribute to the elbow's periarticular anastomosis. Then it gives off the common interosseous artery, which immediately splits into the anterior and the posterior interosseous arteries. The anterior interosseous artery supplies the deep muscles of the anterior compartment. The posterior interosseous artery then gives off the recurrent interosseous artery that contributes to the arterial anastomosis of the elbow. After this, it pierces the interosseous membrane to enter the posterior compartment of the forearm to supply those muscles. Finally, the ulnar artery runs distally to the wrist, where it gives off the remaining 2 branches, the palmar and the dorsal carpal branches, which anastomose with the branches of the radial artery to form the palmar and the dorsal carpal arches. And then there's the radial artery. After emerging from the bifurcation of the brachial artery in the cubital fossa, it runs under the brachioradialis and winds around the lateral aspect of the radius. In the distal forearm, it is only covered by skin and fascia, making it the ideal place to take the radial pulse. Eventually, it crosses the floor of the anatomical snuff box and goes on to supply the hand. During its course, it gives off a few important branches. The first one is the radial recurrent artery, which runs backward to participate in the elbow's periarticular anastomosis. Then, the radial artery runs distally to the wrist, where it gives off the palmar and the dorsal carpal branches, which anastomose with the branches of the ulnar artery to form the palmar and the dorsal carpal arches. Now, feel free to pause for a second and try to remember the 5 important branches of the ulnar artery and the 3 important branches of the radial artery. Now let's have a look at the periarticular arterial anastomosis around the elbow. There are 4 major arteries participating in this anastomosis: the brachial artery, the profunda brachii artery, the radial artery, and the ulnar artery. Having blood supply from different sources allows the elbow joint and its supporting structures to stay perfused no matter which position you put your joints in. The brachial artery gives 2 direct branches. First, it gives the superior ulnar collateral artery in the mid-arm region, and then the inferior ulnar collateral artery in the distal arm. These 2 arteries anastomose with each other, in addition to the superior ulnar collateral artery anastomosis with the posterior ulnar recurrent artery and the inferior ulnar collateral artery anastomosis with the anterior ulnar recurrent artery. Next comes the profunda brachii artery. It also gives 2 branches as it courses in the distal arm, the middle and the radial collateral arteries. The middle collateral artery anastomoses with the recurrent interosseous artery, while the radial collateral artery anastomoses with the radial recurrent artery, the only branch contributed by the radial artery. And now let's switch gears a little bit and talk about major superficial and deep veins of the forearm. The superficial veins are those which can be found in the superficial fascia and are easily accessible, for example, when you need to draw a blood sample. Initially, the superficial veins of the upper limb start as small veins in the subcutaneous tissues from the dorsal venous network of the hand. They converge into bigger venous networks as they progress proximally up along the wrists and the forearm, resulting in big superficial veins called the cephalic vein, the basilic vein, and the median cubital vein. The cephalic vein ascends on the anterolateral surface of the forearm, and it is often visible through the skin. Similar to the cephalic vein, the basilic vein ascends in the subcutaneous tissue on the medial side of the forearm, and as this one enters the arm, it pierces the brachial fascia to run deep to it. Finally, there's the median cubital vein, which is highly variable. It passes between the cephalic vein and the basilic vein along the cubital fossa. Now, the deep veins are located deep to the muscles, and they commonly accompany major arteries as the venae comitantes, which is Latin for accompanying veins. The deep veins start as a tiny network from the superficial and deep palmar venous arches. On the medial side, this network gives rise to the ulnar veins, which ascend alongside the ulnar artery on the medial side of the forearm. On the lateral side of the hand, the deep palmar venous arch gives rise to the radial veins, which climb up the forearm alongside the radial artery. Both pairs of ulnar and radial veins terminate in the cubital fossa, where they join to form the larger brachial veins that accompany the brachial artery in the arm. If you need a quick break, feel free to pause the video and try to remember the 4 major arteries that contribute to the elbow's arterial anastomosis. Now let's have a look at the important nerves of the forearm, which are the median, ulnar, and radial nerves. In the cubital fossa, the median nerve courses medial to the brachial artery and the biceps brachii tendon, entering the forearm between the 2 heads of the pronator teres muscle. Then it travels between the flexor digitorum superficialis and profundus. During its course, it gives muscular branches to the muscles of the superficial and intermediate layers of the anterior compartment of the forearm, with the exception of the flexor carpi ulnaris. As it courses distally in the mid-forearm, it gives the anterior interosseous nerve, which supplies the deep layer of the anterior compartment of the forearm, minus the ulnar half of flexor digitorum profundus. Before entering the wrist deep to the flexor retinaculum, the median nerve gives the palmar cutaneous branch, which passes superficial to the carpal tunnel between the palmaris longus and the flexor carpi radialis to supply the skin of the central palm. The median nerve itself enters the hand through the carpal tunnel deep to the flexor retinaculum at the wrist. Next, there's the ulnar nerve. It enters the forearm by passing posterior to the medial epicondyle of the humerus, from where it descends through the 2 heads of flexor carpi ulnaris. It gives muscular branches that innervate the medial part of the flexor digitorum profundus and the flexor carpi ulnaris, and then continues distally, coursing over the flexor digitorum profundus. At the wrist, the ulnar nerve enters the hand through Guyon's canal, which is a groove between the hook of the hamate and pisiform, 2 carpal bones. The ulnar nerve also gives off the palmar and dorsal cutaneous branches in the forearm, which, along with digital branches in the hand, supply the skin of the medial hand. And now for the radial nerve. Before getting to the cubital fossa, the radial nerve has a branch called the posterior cutaneous nerve of the forearm, which supplies the skin of the posterior forearm to the wrist. The radial nerve itself enters the cubital fossa between the brachioradialis and brachialis anterior to the lateral epicondyle and then branches, where it branches into the superficial and deep branch of the radial nerve. The deep branch pierces the supinator and emerges as the posterior interosseous nerve. The radial nerve, the deep branch of the radial nerve, and the posterior interosseous nerve innervate all of the muscles in the posterior compartment of the forearm. The remaining branch is the superficial branch. This one contributes to the cutaneous innervation of the anatomical snuff box, as well as the dorsal hand and fingers. The skin over the lateral side of the forearm gets its innervation from, well, you guessed it, the lateral cutaneous nerve of the forearm. This nerve is a branch of the musculocutaneous nerve. The medial side of the forearm is supplied by the medial cutaneous nerve of the forearm, which originates from the medial cord of the brachial plexus. Initially, this nerve runs with the ulnar nerve before it perforates the deep fascia at approximately the mid-arm. It then enters the subcutaneous tissue of the forearm, innervating the skin over the medial side. One last pause before we recap. Can you identify the median nerve, the radial nerve, and the ulnar nerve in this image? As a quick recap, the main arteries of the forearm are the ulnar and the radial arteries, which arise from the bifurcation of the brachial artery. The ulnar artery gives off three major branches immediately distal to the elbow: the anterior ulnar recurrent artery, the posterior ulnar recurrent artery, and the common interosseous artery. In the wrist region, the ulnar artery gives the other two branches, which are the palmar and dorsal carpal branches. Immediately distal to the elbow, the radial artery gives off its first branch called the radial recurrent artery, and then gives the other two branches in the wrist region, the dorsal and palmar carpal branches, which anastomose with those of the ulnar artery. The superficial veins of the forearm are the cephalic vein, the basilic vein, and the median cubital vein, which connect the cephalic and basilic veins in the area of the cubital fossa. Finally, there are three important nerves running in the forearm: the median nerve, the ulnar nerve, and the radial nerve.